Memorial Hospital Board of Directors meeting. Our vision is providing quality care close to home, November 20th, 25 at 9 o'clock a.m. The first item on the agenda is called to order, verification of the quorum. We do have a quorum. The next item is the election of officers. So I'll start this out with nomination for chair. Do I have a nomination?
I'm doing it. Sure. Nominate you.
Okay. I don't know if we need a second on that or not.
Second.
Let's do a second like we always do. Is there a second?
Yes.
Second.
Okay. Any other nominations for chair? Okay. All in favor? Aye.
Aye.
Anybody opposed? Thank you. The next item is the vice president, vice chair, I guess it would be. Is there any nominations for vice chair?
Bill. Nominate Bill.
Bill, is there a second?
Second.
Any further nominations? All in favor?
Aye.
All opposed? Well, I'm glad I won that because nobody runs against you. You don't win the election. You feel bad, don't you? Congratulations. Thank y'all. I'll do the best job I can, folks. I'll make some mistakes along the way, but I can assure you that I will do whatever I can do. Try to do what's right. The next item on the agenda. Oh, there's one other item in our agreement there. It's secretary, I believe. We never had one because we got their job to be recorded and to take the notes, the minutes, and stuff like that. That's really all their job would be. Just quickly, I don't see where that's necessary, or we'll elect secretary if the board desires. Just comments. Is there any need for a secretary?
I agree with you. Probably not. No. I mean, everything's recorded and.
Yeah, it's recorded and it's taped, recorded. Heather generally takes
Heather does
notes.
a good job. Yeah. Heather, we recognize you, Heather. Okay.
Melanie, thank you.
Okay, thank you.
Anybody got any reasons? I don't think that's necessary.
Can we nominate
Who?
the lady that's been doing it?
Melanie,
Yeah.
they need to be on the board though.
Oh,
They need to be on the board
well, they
though.
just about are.
Yeah, she just,
right.
yeah, we just staff to the board, so, we can appoint her, because I've appointed her.
Okay, all right. Okay, the next item on the agenda, public comment. Do we have any public comment? No public comment. Next item on the board is approval of the minutes. Do I hear a motion to approve the minutes from the last meeting?
Motion to approve.
Second.
Any discussion on the minutes from the last meeting? All in favor?
Aye.
All opposed? No opposed. Okay. Next item is employee of the month, Mr. David Walker.
Yes, we, for the month of November and usually December, we kind of like skip those 2 months, and so we'll pick it back up in January. We'll do a nomination around our Christmas holiday dinner. We'll
Okay.
pick someone, and then we'll have them for the January meeting.
Okay. All right. All right. Next item, my item, customer service. I still call it customer service. I go to where I get the best service, basically. I think people will. How are we doing at the hospital? Are we doing 1% extra with customer service every month?
Yeah, I think so. We have of course, we have our directors, some of our directors in here, the patient care directors, like Susie Buscrick with the clinics. We got James Osteen, EMS, and we have Courtney Alford, Director of Nursing. I like to call it compassionate care. Customer service, but compassionate care, because, we want to be very compassionate, to the people, that we serve. But not only, like I said, not only in our direct service patient care areas, but we have other areas, even in, front desk, greeters, lawn maintenance, or even when we're cleaning rooms. So we want to continue to improve in that area. We're not there yet, but we want to continue to make strides in that.
Okay. With regard to customer service, I think it starts initially getting people into the health care they need. With that, and I'll be honest, I don't know if anybody really understands, I guess, as I understand it, that Medicare will be no longer like it used to be. Is that correct?
Yeah, it'll be some
There'll be
changes
some requirements.
in Medicaid. All that's going to change. Yeah.
Yeah. Are we prepared to help those folks walk through and do what they need to do with regard to paperwork? Susie, have you thought about that at the clinic?
Yes, I was just gonna bring it up today.
You're gonna bring it up? Good. I won't say nothing else, and that's great. You're already looking at that because our customer care it does start before they get into the system, you know, with the insurance. And people don't understand the insurance.
Yeah.
I don't. I go to the doctor and give them $25. I don't know. Maybe I should give them 30. 1 year it's 40. 1 year it's 20. You know, this doctor's that doctor's that. So I think we need to remember our customer care starts before they come to the clinic or they get in. And so, Susie, I think it'll affect our clinics quite a bit, I guess. So thank you. I appreciate that. Any other board members got anything to say about customer care? I know I rattle on about it, but I think it's very important.
Yeah, and most every board member I think I've spoken to about this because we've had issues and we correct the issues.
Well, that's part of customer care.
Part of customer care, compassionate care.
We're not going to be perfect all the time, and we learn from what we do wrong a little bit, definitely. Okay, the next item is clinical services report. Ms. Courtney Alford.
Good morning. Just a few updates. Last time I told you we lost 2 nurses, full-time night shifts. I have already hired those other 2 PRN night shift ones to come on. One's already oriented, finished her stuff with Melanie and oriented last weekend, coming back to orient some more this weekend. And the other one's set to come in with Melanie soon, and we'll get her on the schedule. So thankful for that. I wanted to kind of do a little shout out to NHC. We have a great working relationship with them, one of our community partners, but they actually sent us 2 of our swings that we currently have at the hospital right now. So I'm thankful for them.
With who?
NHC, Tammy Hardy and her group for
okay.
home health care.
Home health care, good.
So
that's great.
Yeah, thankful. We send them a lot of patients, and you know, when we can, we always send them to them because they're the local agency. But she actually sent us referrals. I gave my contact to 2 of these people who contacted me, and we got them in for swing. So thankful for that.
What is the NHC? What's the name of that corporation?
It's our health care. I don't even know what it stands for, to be honest with you.
It's home health care, though,
It's
right?
home health care. They're in Carabel. They're actually right next to our EMS station in Carabel, in that little strip mall, mini mall.
They won't be soon, right?
I don't know if they're relocating.
They won't be what?
Been there forever.
Lanark, don't they get relocated to Lanark?
No, we talking about. Yeah,
No, NHC is right next to our
Yeah,
EMS station.
What we have in, as far as EMS and Carabel, isn't that going to Lanark? or not?
Yes,
Yes.
EMS
Yeah.
is.
Yeah, you correct, EMS.
And
so,
that's been set by the county commission to have an opening in the next couple weeks or something like that.
yeah, and once we get that information, we'll send it to the board members if you want to travel to that. It's going to be a nice facility. But NHC is National Health Care Corporation.
That's what I was
You know,
thinking.
home care.
I was-
So it's, you know, we don't really know the abbreviations too much, but we call them NHC. They do a great job here in the county.
Do they have multiple offices in the Big Bend area?
Yes, I mean, they run for our county out of Carabel, just in that one office, and that office covers Port St. Joe, Gulf County, Franklin County, but there's offices all over the area, yes,
So
sir.
they basically have like visiting angels or something like that? Is that what you were talking about?
I don't know what you mean by visiting
Well,
angel,
they
but
send the nurses in.
they do. Well, we send referrals, so if our patients need therapy passed, like if these swing bed patients need therapy at home, we call NHC. They have physical therapists and all kinds of therapists. They have nursing that provides care, does med management, things like that, once our patients get home, or any patient gets home, even if they're not a swing bed patient.
Yeah, and so for the people listening, swing bed mean inpatient rehab. You know, so NAC is like a step down. You go to the hospital, you know, you need some further rehab, you go to Weems, any kind of hospital, we send you back home. These, what they call home health services and stuff.
Will they be one of the groups that are eligible for these funds under the transformation project?
Yeah, you know, they could be, but I don't, you know, there's nothing in there for like home health rehab in a way, but, you know, I'm sure there'll be some questions asked
Okay.
for them to be a
That's-
part.
That's all I wanted.
Yeah, yeah. And we'll talk about that later.
Okay. Courtney?
Also, one of our, sir?
Go ahead.
No. One of our PRN nurses, Tara Huckabee, is now the school nurse at Franklin County School. So we've been donating a lot of our expired nursing or hospital products, you know, different like tubing and things like that, so that they can use it in the classroom. But she's bringing her class to do a field trip at Weems in December. So we're
That's
all the
good.
department
That's great.
The
managers.
nursing program?
Good.
It's not really
Is it CNA?
nursing.
CNA.
Yeah, it's CNA and then they're just doing like medical teaching. So a little bit of this, a little bit of that.
That's cool.
But she's great. She's on our PRN roster, and she's a great nurse. And so it's a good opportunity for sure for the hospital. Makes it a little easier that I know her, and you know she works for us sometimes too. But they're coming to do a field trip middle December. So she'll bring her class and talk to all the department managers. We'll show her around, and we're going to make some visits out there throughout the school year as well.
Yeah, and one thing about that too is that previously, you know, we had some of our department managers go into that classroom at the school, you know, just talk about health-related services. I know, I think not Randall, but James probably could have been out there too, talking about EMS with that class. I know Louis did it initially as well. So with Tara, you know, building that connection there, being that she's a local nurse here, partner, you know, still employed at Weems, and that connection that Courtney has with her, you know, that'll help also. And these kids, once they get ready to go to school, they can go to LPN school, and then they may think about coming back to work in one of our settings. Or either they go to LPN school, then go to RN school, you know, and then think about coming back here working. And so I think that's a good connection that we have with Tara, because we know her, you know, and Courtney's in constant communication with her, so I think that's great.
Also, we have another BLS, ACLS, and PALS class coming up, so I just like to mention the education because I know Bill likes to know about that. So we do them twice a year. She'll be coming back in the end of December or early January. The date's not set yet because I'm waiting to see who all needs it first on the sign-up sheet. But we'll have that. We just ordered the new books for that because it's a new 2025 set of new standards for that. So, and then we are going to participate, Weems, in the health fair that's at Living Waters on 12/6. A Saturday. I don't know if y'all, it was the health fair that was originally scheduled for last Saturday, got rescheduled because of the air show. So we will have a table and some people out there to represent the hospital as well. And the last thing is our,
Big Ben Hospice. Can I talk about that?
yeah, just yesterday.
Yeah, then we have a day of remembrance coming up.
Yes, we do. We have, Mr. Walker and I are on the Big Ben Hospice Board, so we meet with them monthly. And then we have our Day of Remembrance coming up for the Giving Tree, the Remembrance Tree. There's a tree in the courthouse, there's a tree at Carabel Health and Rehab Center, and then there's a tree
East Point.
in East Point.
Clinic here.
The clinic care, which is in East Point by the East Point station. So we're having that Day of Remembrance. Mr. Walker's got to go and take some pictures today, I think, for that. And then we'll be going to Carabel Health and Rehab, where we'll meet hospice and all kinds of people there on December the 10th, I believe, 10th or 11th.
11th, yeah.
11th. So, and the hospital's going to donate all the cookies for that. So we're going to take all the baked goods for that. So we'll do that. We meet with them. We met last week with hospice for the advisory board. So also a good community partner we're thankful to be a part of as well. They actually had two of them come yesterday, and Mr. Walker and I had a meeting with them, and they're going to do some updates on our hospice patient room. So get us a new chair and do some maybe little plants outside, plant a new tree. So try to make it a little cozier for these patients.
Have we had many hospice patients?
I think we've had 3 in that room. We talked about referrals too and some different things. They're coming back to meet with us in January, and then we're probably going to bring them to you guys in February so that they can kind of give some updates on their care and what they offer to the community.
And they also, you know, in communication with them, you know, last legislative session, you know, they applied for a big mobile bus. And they do palliative care, and they have not really been using that bus as well. So we talked about, you know, maybe using it, you know, doing some, like a mobile primary care clinic, you know, one day a week in some of the areas, like maybe Lanark Village, you know, or Highland, some places outside that people are really not getting touched. But that'll be more when we talk about them with them in January, you know, to strategize, you know, how to use that bus, you know, they want to offer it to us to use. So there'll be some further conversation we'll update the board on.
I think that can be a good opportunity, though, because we'd have to obviously work with Susie. We hadn't told her this yet because we just met yesterday. But if we were able to schedule her like landmark patients for that certain day and we have the bus there, they don't have to travel, and have
Yeah.
one of her providers out of the clinics
Yeah.
go to work on that bus, which has 2 full exam rooms in it. Or even do it in East Point or even on the island, you know. It's a good opportunity for us to kind of help the community and come to them some when we can. So I think it'll be a good thing. We'll discuss that more in January and bring it to you guys in February, so. And the last thing I had is just all our holiday activities. We have our Thanksgiving lunch at 12 Thursday. If anybody wants to join, I think Heather sent it out via email, and we'll keep you guys updated on our Christmas activities too. We're gonna have our Christmas dinner. We're gonna have cocoa and cookies one day. We're having soups one day, and then we have a holiday cart we push around and give everybody little holiday treats and different things like that. We have a holiday committee, so we're getting all that going, and we'll send out the activities once we get that made, probably the 1st of December. You guys are welcome to come to any of that stuff and join us.
You gonna make that casserole, you?
I am. In the morning before work.
Is there something this Friday?
Yes, it's the holiday, the Thanksgiving dinner's Friday at 12 o'clock in the cafeteria.
I can't be there.
So anybody that wants to come, the hospital provides the hams and turkeys, and then the staff all bring desserts, casseroles, whatever. So
And when is
12
that?
o'clock tomorrow.
Friday at 12.
Tomorrow?
I gotta go to a funeral, because of mine died.
Well, maybe you can join us for the Christmas one.
Well, I'd like to, I guarantee you.
We'll send that information out the first week of December with all the holiday activities for Christmas stuff as well. So,
Folks like that, everybody there, it's very enjoyable.
yeah,
She said 12. Yes, ma'am.
that's all I had, unless anybody has any questions for me.
So your nursing staff, you're feeling good about it? right?
Yes. Yes, sir. Yes, sir.
I have a question. I don't know if this is the proper time, Mr. Chairman. What was our role or participation in the air show?
Well, we had, EMS was there,
I understand
yeah,
that.
and of course, I was at ticket booth all day.
Yeah, you
know.
were.
So that's pretty much what our role was at the air show.
And they had no medical issues out there at that.
You know, we had no medical issues, because of course we had EMS, we had fire department, of course Craig is part of the fire department, they were out there. There were no medical issues at that time. Now, if it would have been a medical issue, EMS could have stabilized them, got them over to the hospital. You know, hospital was on alert, you know, that we had this show as well.
Thank you. That's such a big, gonna turn into a big function next year.
Yeah, and it was a good function. It was a good function. You know, I was at the ticket booth and I put my head down, looked back up, a whole line coming back again, you know, so there's a whole lot of people there, you know, very good event though, very good event.
Okay.
And Dr. Conrad just got off a 36-hour shift, so he's not going to be here this morning.
I don't blame him.
So. But I don't think, he said there's nothing to update. If you guys had any questions or concerns, just let me know and I'll get with him about that.
I want him to say it's a transition. We've been seamless with our doctors in emergency room, correct?
We have, yes, sir, I think, and Dr. Dietzer's there right now, so I think that leaves us with only one more that needs to sign the paperwork and get things taken care of. We'll get everything addressed to Dr. Dietzer this afternoon.
Okay.
Yeah, and then we'll get it over to Mike Marone, have the chairman sign the agreements.
Okay.
And so all the other physicians have signed.
Okay.
And I will say again, it's opened up a good opportunity, in my opinion, because we get these good reports, and Mr. Walker is sending them numbers, so,
Okay,
you know,
good,
it kind of
good.
increases the communication, I think, which I think is a good
Yes,
thing.
absolutely. I think I like that better. Okay. Anybody got anything else? Courtney? Anything else? Okay. Next is the EMS update, Mr. Osteen, James Osteen.
Good morning. All right, let's start off with, we were talking about the air show. We were at the air show, we did participate. We actually had a dedicated ambulance and a crew working on the UTV out on the wood line, just in case, God forbid, a plane would have went down. No incidents, nobody got hurt, nothing. We didn't have any patients at all. Unfortunately, after the air shows, when they had that fatality wreck out front there on 98, but that wasn't nothing to do with the air show. We will be at the health fair also. We're gonna have a booth set up out there also on next on the 6th,
Yeah,
December
December
6th. Aaron gave us the green light to move into the new Lanark station on this coming Monday, the 24th.
Oh, wow.
There are a few issues that need to be addressed still with the new station, but hopefully they'll be ironed out over the weekend. We did go ahead and,
Quick question.
go ahead.
Who inspected that building to make sure it was, you get a CO, certificate of occupancy? Did somebody do that?
They did a final walkthrough yesterday, I believe it was. I'm not sure who inspected it, but they did do a final inspection yesterday.
Should an EMS been involved in that?
Um,
I mean, it's where you're gonna live, right?
It is, but the county is taking care of that. I'm pretty sure. Well, I can't say pretty sure, but I'm not sure who was out there yesterday when they did the final walkthrough. That'd be more of a question for Mr. Marone or Miss Aaron. I'm not sure.
You understand where I'm going, Mr. Chairman? I think that if they're gonna live there, that they should.
Well,
have had
the only
the
thing,
opportunity to
your
go through it.
inspection is to make sure you're with codes and everything's built correctly. As far as the EMS, and I went into a lot of new places, and I really had nothing to do with the final inspection. It was all your architects and your the people that issued the building permit and stuff like that. Now, and I would think that that it's a general layout. Have you been in it?
I'll be out there tomorrow. They're actually
Have you been in
delivering.
it yet?
No, I have not.
Did you see the plans?
I'll be out there tomorrow
Uh-huh.
because they're delivering the appliances tomorrow.
Okay.
So I'll be out there.
You know,
tomorrow.
I don't know what to tell you. You know, I don't know
I
what to
just
tell you.
know that in past experience, whenever, and I'll just go relate to the history, whenever we built new toll plazas or we built any type of auxiliary buildings, we always had someone that gonna live there or do their work there, go through it and see if everything was in order with regards to how they were gonna do their placement. It's just a planning type situation, because you could go in there next week sometime and find out, well, this doesn't work, that doesn't work,
Well,
next thing you know, you're
that's-
raising Cain.
That's gonna happen. My thing is, you don't know what's going wrong till you move in, just about, too. You know, I hate to say it, you know, so, go ahead.
I was working with Mr. Walker after our last meeting about the extrication tool. Well, we went ahead and purchased. I got the quotes on that. We looked at the quotes and we went ahead and purchased one set. So
Okay.
one set was purchased. It's going to be hand delivered by the company, and they're going to give us free training on it also. So they're not going to charge us to train us, or we're not going to get charged for shipping and freight because he's going to hand deliver it. They're actually it's Rescue Systems Unlimited, which is the Genesis tool. Now they actually have a shop in Tallahassee. So if anything happens, we can take it to Tallahassee, have them fix it. So it's just going to be I think that was the best one for the. There's the two other quotes. I wasn't sure. I've heard of one of them. I hadn't heard of the other one, so I wasn't familiar with it. One was called Darley. I've never heard of them.
You're fine with this one though, right?
I am because not just I got them because Alligator Point has a set, Wakulla has a set, Apalachicola Fire's got a set of the Genesis tools, so everybody has the same tool.
Good.
So I think it was good to keep it where everybody knows how to
Sure,
use it.
exactly. Sure.
I know you wanted to revisit potentially getting 3 more sets for the ambulances, but at this time, I think we just table it for now.
Okay.
Um,
Let's-
One, I don't know exactly where we would put them on the ambulance. I mean, I know we can make a spot for them someplace, I'm sure, but I just don't know where we'd be able to put them.
How's the board feel about that? Hold on.
Yeah. I think
That's
the best
why
thing
we
to do.
asked the question.
Yeah,
Where you gonna
exactly.
mount 'em
Yeah,
and where
you asked
gotta
that
put 'em.
question.
And not to
Well,
mention,
let's see what we're doing, and then if we think we need them, we'll come back.
not to mention with this set that we have, I'm gonna have to get extrication suits for the guys. So if they're using them, they have to have this protective suits.
Really?
So that's gonna be accrue another cost. And if I put them on the ambulances, then everybody, all of our crews are gonna have to have them.
Oh
Okay.
my gosh.
Oh, goodness, okay.
So we're looking at basically about $600 a set for the suits, the helmet, and gloves.
I hope them are reusable. I mean, yeah, okay.
Yeah, they're not disposable,
They're not disposable, good.
but they do come in different sizes. As
we not
everybody's
know?
built in different sizes.
Did we
so
not know this before we got into this?
It was my bad. I wasn't even thinking about guys. You know, the wearing personal protection. I was more thinking of the extrication tool to prevent what happened before the delay of extrication.
Do they have to put on a helmet?
Yeah, they have to have the helmet and the face shield for eye protection, gloves for hand protection, and just because, well,
Metal
you
filings
cut
and so forth.
you cut stuff, it's sharp.
Glass,
Metal's
yeah.
going to be sharp, so it's
You
got
get
to
a-
have some kind of protection.
You could get a fling back at you and all kinds of stuff.
So that's why I said let's table the
Okay.
3 other ones for the time being until we can get further down.
Figure out.
I am looking at Alliant Purchasing right now, trying to figure out for the suits, the extrication suits, seeing if we can get a discount through them. So that's why I'm working with them now, trying to figure that out.
Okay.
Do they have specialty gloves that come with those suits?
There's gloves there's extrication, what they're called extrication gloves. They're almost like firefighter gloves typically. I mean, they're thick, they protect their hands well.
And that's not a separate item.
Well, it's the suit's separate. The gloves are, of course, everything's separate. They don't make everything all in one. all in
So
one
is
thing now.
$600, let me get
That's
back
for
to the
everything.
basic. Is the $600 cover all of this?
Everything.
Okay.
Other than that, I mean, if y'all are good with tabling it, I'm good with tabling it for now. We'll just we'll come back at that later on. As you know, we signed a contract, a MOU with Gulf State College for their students to come ride with us. When that starts, I haven't talked to David yet about this, but we were looking at maybe potentially giving the FTOs maybe a pay bump, $1 or $2, just to be a preceptor. I don't know how y'all feel about that. But that's just something, just something to think about. I'm not asking for that right now. I did hire one more full-time medic, so once everybody's out of orientation, we'll be fully staffed.
Okay, good.
You got the other two from the last minutes? Set of minutes, you had 2 part-timers or something like
Yeah, I
that?
got 2 part-timers, and I had 1 full-time from the last one, and then I just hired one more full-time.
So nobody's left, it's just basically you're.
I've got to get them through orientation, and then I'll be fully staffed.
So that's great news.
That's
This
awesome
is probably the first time
Good.
we've been fully staffed. And James and I, we were talking about a strategy to tell these individuals, get on board now, because in January, it'd be too late, because when people get in these career service positions, many times don't want to leave. And so that's been kind of helpful for us as well.
Good.
In, James, these are students from Gulf Coast and they're basically gonna ride in the
Yes.
EMS?
They're going to do their clinicals with us on the ambulances to get their clinical hours required to graduate from either paramedic or EMT, their course.
Pick up some more staff too, possibly.
That could potentially turn into, it's good for recruiting.
Yeah, sure.
Yes.
So there's 3 people, there'll be 3 people on the vehicle?
Yes.
Okay.
They'll
Whenever
be
that-
observing, right?
Whenever that happens.
They'll be there to observe, right?
Yes. Well, they're there. They can be hands-on.
Can they?
I mean, that's
Okay.
what they're there for.
They're there for,
To
okay.
actually do the work.
Okay. Now, here comes the question. Insurance-wise, are these people covered just in case they get hurt?
They are. They're covered through the college. All their stuff's
Liability.
covered through the college.
Liability and, do we assume the liability of the college?
Yeah, well, we have our own insurance, but they also had to add us as an additional insurer, so they got to have their own insurance as well.
We have paperwork that
Yeah,
Yes.
yeah.
shows that, okay?
Yes.
And this is something that, once we get this rolling pretty good, you know what I mean, it's gonna help with recruiting as well. And, we may have a lot of students in this area, that want to go into that field, but they can come back and work within the county, and that'll help our homegrown kind of deal here.
And the last thing I have is the overtime. Unfortunately, it went up a little bit from 15,553 last month to 19,844 this month, and it's primarily due to covering the air show and keeping from having to down the ambulances to 2 trucks.
Yeah.
So,
Another thing too, that, we had the air show, we had the seafood festival, and so anytime you have any of these kind of events here in the county, we kind of have EMS to help out with that.
but that's all I have for you guys.
It's good to me.
You aren't gonna tell us about moving? Or have you already told us you were moving?
No, I'm moving my office out to EOC for the time being. I think I mentioned it last time because I was opening up my office to make a bedroom, another bedroom for when the students come and ride. We could potentially start seeing students middle of December, potentially. So
Bedrooms, is that the unit have behind
3. Well, no, my office is out. There's 3.
Anybody got anything else? Thank you, James. Anything else?
That's it.
Thanks,
Appreciate it.
James.
Yeah, James doing a good job. Like I said, this is the first time we're fully staffed, and I really like the connection with Gulf Coast. And then with Tara being at the school, that's going to be another connection too, for our EMS in the county to connect both ways.
Okay. James, are you does county understand what all, are we giving them a report, or they just get it from our minutes, or
As far as what?
everything we're trying to do with EMS?
Yeah.
They're aware of it.
Okay, good.
Yeah, James started giving them, I think you go monthly now. with-
I get the.
You do you? Okay, good, because
Yeah, with
that's
other
still,
directors.
that's our EMS. It will be our EMS when the county takes it over too. I mean,
And then we're still, sorry.
it's still
We're still slated right now for April 1st
okay.
to go over to the county. I had a short meeting with Louis yesterday, and the director application process will start probably within the next couple weeks.
Okay.
They will open that up to whoever wants to apply to be the director, and whoever gets it will potentially start February 1st or that first pay period in February.
Okay.
And then from there, you'll open up the application process for all the other positions, the paramedic, EMT, and captain positions, and then they'll decide from there, how we're staffed as far as who gets hired, and potentially everybody's going to get hired because
Yeah.
I don't see a lot of people applying, extra people right now.
Okay.
Then they're going to want to feel us out first.
Yeah, sure.
Mr. Chairman, I think I'd like to ask the board, don't you think that we ought to get a copy of the insurance, or they have something that shows that these people are covered? Because we're not a rich county.
Are you talking about the students?
Yes,
Rob Wall?
yes.
Yeah, sure.
And
There should be
have the county attorney look at it, make sure that, I think that
There
that's
should
the
be
due
some-
diligence that should be done.
They should have some kind of certificate showing that the school is picking up the coverage for those individuals, not only the liability and med mal, but also the workers' comp.
Well, why don't you
Right.
get directly with Mr. Walker and James and
Yeah, we'll get
whatever you need, we'll get.
Well, we'll get what we-
What you were talking about, John? You know?
Yeah.
Just
Yeah,
if
I
we
agree.
could get
I agree.
if we could get the certificate
Yeah, proof of-
proving that the
yeah, proof
coverage
of insurance.
has been placed on the policy, then that would provide us our
Take care of it.
protection, yes.
Take care of it.
And the proof of insurance is attached to the MOU, so we have it.
Well,
Oh,
let's
yeah.
get a copy of it, and let's send it to county attorney too, double check that, okay?
All right.
David, you gonna get that to the county attorney, let him review
Yeah, let me go back. 1, 2, 3, yeah. Yeah, Michael Schuler reviewed the MOU. You know, he had some changes
Right.
that he wanted to add, so we sent that back to Gulf Coast. Gulf Coast added what was in there. And the proof of insurance certificate, we can, from Gulf Coast, you know, make sure that's in there on our end. And so
Okay.
we'll get that and review it and share
Got
it.
what you need, John? Good, good. We need it. Anything else? Susie?
Good morning.
Good morning.
Happy National Rural Health Day. Today is National Rural Health Day. So I just have a quick couple of reminders from the last meeting is that we will have the clinics closed for patient appointments during the Christmas holiday, so the providers have some time off with their families. But staff will be there to answer questions, answer phone calls. We'll do blood work over at the West Clinic because we're right next to the hospital on campus and don't need a provider there.
You say Christmas holidays now. How?
Christmas week.
Christmas
So,
week,
yes,
okay.
because during that time, we're going
That's
to take the
reasonable.
opportunity to do renovations in both clinics. So we'll be doing painting on the outside of the East Clinic in Carabel and painting on the inside in the West Clinic in Appalach. We have a humidity problem there in the older building since it's so old, and so we just want to touch up things, and it's a good opportunity while people are taking time to be with their families. We'll also, as of December 1st, start increasing, like I said before, the venipuncture fee to $20, and we're one of the few people in the area that do it for outside labs. So it's just a matter of cost and to make up for supplies. And we will be doing a different venue with Quest, who we use for our self-pay patients. So we're going to allow the patients to be billed by Quest, so they're handling their own monies. We're staying out as the middleman. And so the patients can make payments to Quest for that. There'll be a slight increase in the cost of the labs, but it'll give them an opportunity to be able to pay in payments. So that's that. And of course, it's that time of year for insurance. You brought up insurance before. So we're encouraging our patients to really take a look at their insurances. Make sure that if you have an HMO plan, you have us designated as your provider or we cannot see you. It's different than an ER. We're not an ER. We are a clinical office, right? So they have to have our supervising physician or the facility on it or the provider's name on it. It depends on the plan. But so patients know ahead of time. And we do tell them as we're making their appointments, and I do a lot of education when we're talking to the front desk staff, that patients do have to designate us for HMO plans. It's better for them to designate us for a PPO plan because it's a matter of us being able to do prior authorizations and referrals for the patients. If they come to us for an HMO plan and we don't have their name, we're not able to do that. We're not able to send you out somewhere else. And the claims may not be paid. So you have to,
Now,
we
what
have
was
to
that?
really.
If you're on a HMO plan, what?
HMO plan has to have us on their card.
Okay. I got
Meaning
it.
that, you know, whoever your,
HMO, you have to be in network.
Yeah, I know.
So
I
they
know
have to
that.
have the
I know
network. The
that.
PPO, you don't have to, you can go outside of network. and-
Right, and a lot of people don't understand that if they just get
Yeah,
signed
I
up to a
understand
new
that. Yeah.
plan.
Like Blue Cross is a PPO.
Yeah, and they just have to realize who's on their card. Now, a lot of the insurance companies now, they're no longer putting names on the card because they want to save from having to reprint it with a new provider's name on it. So they don't want to have to push more plastic cards out, so they just leave it blank. So it's really on the patients to understand their plan, and the insurance companies usually typically pick somebody, a provider that is within 25 miles of their home. So. But what we're also going to do is try to encourage everybody, if you need help getting on Medicaid, because there's a lot of changes with Medicaid, we have Joanna Page as the financial assistant at the hospital. If they call her, she'll help with the financial assistance packets, which is a great program for patients in the Franklin County. And she'll also help with signing people up for Medicaid. So.
You're going to
Yeah.
encourage folks to do that, correct?
Pardon?
We're going to encourage folks to do that.
We want to encourage, yeah, and I try to tell people, even the self-pay patients, just to even try to see how much you might make on the sliding scale fee.
Right.
Because any percentage to help you is a great thing, right? And some of our plans are Advantage plans. That's another thing if they want to talk to us about it, but they really need to look, the Medicare Advantage plans, at what they're getting into, because all these commercials that are coming out on TV, they're a little bit deceiving. Sorry, anyone who's watching from United. But, you know, they're going on the idea, oh, I'm going to get a $25 grocery card, or I'm going to get some prescription plans. But in the back end of it, they're not paying us. They are also making these promises, but they're making it harder for patients to get care with referrals and prior authorizations. So there's a delay in care, and that's more important to me, that we can get somebody in the door somewhere that actually accepts that plan than whether they get a $25 gift card.
Yeah, and I think, when you look at plans like this, and that's not only with outpatient, even when you inpatient, I'm just talking from a personal predicament here with a family member that had a certain plan and had to get kicked out of the hospital because the plan said, okay, you used up your 10 days, you got to go, but still needed the care. Now if they would have had a different Medicare plan, that wouldn't have happened if they had straight Medicare. So you got to be very careful kind of plans that you choose. And Susan, we're doing some education with the patients, because of that. But what's going to happen, with the whole ACA type of stuff going on now with this insurance stuff, a lot of individuals, plans going to change. People going to get kicked off insurance. We're going to have a high self-pay area. And then these individuals, instead of going to the clinics, most of them probably going to go to the ED as uninsured patients. And so there's a lot of things that's coming, but our job, we're trying to educate the patients, and I try to educate people in the community who I meet with and know about, these shiny $25 they want to give you on the back end, but then you need to see what they give you for your care. If you need to be hospitalized, what happens then? But that's, that's ongoing. That's like a process because the plans changes. That's just my soapbox
I'll
on
tell you
that.
something about CHP. I guess they got in a dispute, and actually the contract or whatever wasn't resolved with CHP and I guess Franklin County. Anyway, historically, if you didn't do anything during the period for insurance, you kept what you had. Well, since they were in that dispute, they automatically put me on a
Florida Blue, right?
H whatever right there.
Mm-hmm.
Yeah, so actually they gave you another week, and I'm hoping some people didn't get their coverage messed up. I got mine right,
Yeah, well, no, we had a couple people say from the CHP process that they automatically got thrown over to Florida Blue and they
I
weren't
did,
aware of it.
Florida Blue.
But I just encourage them, go back to what you're comfortable with,
Well,
because,
I went back to that. but
again, there's that
they
gap
got
in
it
care.
resolved like only a week before the time period ended to change plans, with the
Mm-hmm.
state and stuff. So I got it, but I'm afraid some people got messed up.
Yeah.
Okay, I got a question for you.
Okay?
Go ahead. Are you finished with everything?
Yeah, I'm good. No, the only other thing I want to encourage people, if you do have a question about bills with laboratories or any kind of problems with, services you'd like to see, compliments as well, just give me a call. I'd appreciate it because because we're county owned, a lot of people have that phrase in their mouth towards staff, and this is really just a courtesy that give me a call. I'd like to resolve it because I'm there working every day, and there's 2 and 3 sides to every story, and I think if you come to me first, I can get a better resolution for you quickly with billing and things, instead of saying, well, I'm going to go to the commissioners. That's fine, that's your prerogative, but the commissioners don't work there, right? So I just think that if you have a problem with your bills, I'm open, my door's open to call me or leave me a message, and I'll get right back with you.
I think we're fortunate here to have the 2 clinics that we have with the providers we have.
We do, we do.
And another question,
Yeah, but Susan,
with speaking of providers, our last meeting, we approved the incentive for the providers.
Yes, we did, and they've both been educated about it. They had a meeting just the other day with
Are
everybody.
they generally happy with it?
Susan can talk to it more, but they seem to be very happy with it. And like I said, this is something that we've been trying to work on. It's just, we've been behind the scenes for a while, but they're very happy, that we're moving towards this, as an investment into them, because they're it right now. So thankful that we
And
were
they-
able to
they
do it.
And along those lines too, I heard everybody talking about schools coming in. I'm not sure everybody's aware that we also do preceptorships for nurse practitioners. And Dana Whaley has been doing a great job. They like to go up to the East Clinic because it's a little bit more action going on. But Dana does a great job with her students there, and we've turned out three or four nurse practitioners from her oversight. So I think that the clinics and it's just a good thing for everybody in the community to have.
Yeah, well, we have one right now that's working for us.
Yeah, one of the nurse practitioners that worked for us part-time was one of
Oh,
our
really?
preceptors,
Yeah.
yeah.
Good,
Amanda
good.
Beach,
Yeah.
so.
And we have another one that's probably coming.
I know we
Yeah,
had
we have
talked-
one coming in January, February, our time.
We had talked about that incentive a long time, and we had a board member pick up the ball and run with it. Thank you.
You're
We need to,
welcome.
that was good.
I have a couple of questions. when
Go
you
ahead.
finish. Two questions.
Okay,
The first one probably pretty easy. The second one might be a little difficult. The first one is, how are we advertising the hours of operation for Christmas?
it's on Facebook, it's on our website, we have actual
You're
paper
posted.
signs on the doors.
Have we put out any public service announcements on it?
On the radio?
Yes.
Not yet,
Oyster?
no. We
Yeah.
can, yeah, we can.
Okay. The second
I-
question, a little more difficult, is that even for myself and being part of CHP, all of this sign up every year causes a lot of consternation.
Mm-hmm.
And are there companies that provide customer service you can hire and bring in, and they can sit there, one of their representatives, and when people come in, if you advertise it, if you need an explanation on something, that we could hire to come there and answer those questions for these people?
Not that I'm aware of. We used to sponsor the insurance companies at the clinics, where they would come and, they're not allowed to be in the building, but they were allowed to be out in front of the building. It's their rules and insurance policies.
Bill, on
but-
CHP, People First were real good with me when I talked to them.
Yeah.
You know, People First.
Well, People First is the state
That's
organization.
state.
Well, I know, but they're the ones that falls to them. They put
Right.
Yeah, well,
the
And there's a-
information out, and they were real good with me.
it all depends. Okay, People First is for the people that's working with the state.
Yes.
State, but you have other people that may not work with the state. Could be
Yeah, I
county.
understand.
Well,
could
there's a group called Shine that works with Medicare patients, to tell them all about how to sign up for that, and there's signs in the clinics for that, and I think they posted in the local paper as well.
I just think a lot of people get messed up on their insurance because of the fact they don't understand it all. And until you get
Oh, I
somebody
know.
that can come sit down with them and make them feel comfortable and explain it to them, may take 30 minutes, may take 15, may take an hour. But they won't come back the second year because they'll understand it. But there should be a program someplace, there should be, that can help the less educated people to know and understand what's available.
Well, you'd hope that the insurance companies themselves are doing it right, because they have a lot.
No,
of
they're calling up on the phone and saying,
Right.
do you have this? And they got all these hacks doing
Right.
this and that.
Now with the with the new Rural Health Transformation Grant, we'll talk about that later. There are going to be some monies for entities to apply for, so they can begin to help individuals learn more about really Medicare and Medicaid. You know, for example, if you get some Medicaid Advantage plan, I don't know if it's going to be Advantage, but maybe Medicaid plan, and you don't understand it, you know, the organization can hire like a navigator or a person, you know what I mean, to talk with that individual, that group, to kind of like educate them on the plan. So there's some money in the grant, the new upcoming grant for that process there. I don't know if it's going to cover your commercial insurances, like your CHPs, you know, and all of that, but I know it probably will cover your Medicaid plans that the state have.
I just think it's an opportunity to hit the customer service side or customer care
It
side.
absolutely is.
of
It
the
sounds like,
equation, to have a program, bring people
Sure.
in that are professionals, sit them down and let them have the public come in there when they are available to come and explain to them what their options are so that they feel comfortable when they go home.
Sure.
well, that sounds like there might be some monies for that too. you
Well,
know.
that's the way downstream, that transformation program.
I don't know how you do that.
Yeah, and that's gonna really touch on the Medicaid, Medicare portion, and so we look at, as an organization, you know, do we hire a navigator? It could be a case manager, but insurance navigator, you know, for the hospital as well as for the clinics, And that way, you know, that person can do what Joanna is doing. With Joanna, she helps them get on, but she got other things to do. But that person could be focused on, you
Just
know,
that.
enrollment, education, you know, different events. If we have community events like that health fair, that person can sign up
Now
there.
you're talking my language.
You can put stuff out, you know, for that person to come in. So we'll put that down as something, you know, strategically. And that will help, that may help us also as we begin to look at when people get kicked off the system, you know, and need to be signed up on something, because we want to make sure they get signed back up on a plan instead of going to uninsured.
Yeah.
You know, so we can put that as a
Yeah, absolutely.
strategic goal, something like that. So we'll have that. Thank you, Susan.
Okay.
Thank
Also,
you.
while Susie's up here, and I told her today she probably just needs to, she's not gonna be here for that long. There's something on my report, is the Carabel Retail Clinic. You know, we're still looking to refresh those numbers, so hopefully by our January 29th meeting, you know, we'll have some refreshed numbers that we'll present to the hospital board, and then we'll go present it to the county commission as well. So,
Okay.
we should have some refreshed numbers for, you
This
know,
for
the
the
pharmacy.
pharmacy?
Yeah, for the pharmacy in Carabel.
Yeah,
Okay.
good.
Any other questions?
I got one.
Okay,
It's Christmas time.
yes.
You don't ask for much, and the clinics are really running good. One thing, if you could have for clinics, what would it be?
We've already
Except
talked,
a raise.
not for, well,
Just got a raise.
really?
One thing.
One thing I would like new beds.
She
exam room
deserves
beds.
it.
Yeah.
You like what?
Everybody got a raise,
Yeah,
yeah.
everybody got a raise.
You like
deserves
what?
it.
Yeah.
I'd like new exam beds in the clinics.
And you what?
Exam room beds,
Yeah, yeah.
Exam room.
Exam room.
Something to stretch you out of.
yeah,
And so
because
that's
the ones
part-
we have are older, but being in older buildings, you get everything rusts a little bit more, and it would just be nice to also have ones that are capable to hold much larger people, that they can go up and down. And they're costly, so we've been working on it with our
Yeah.
goals for the upcoming year.
Yeah, so one of the things we mentioned, you know, so you have about 4 beds in the, well, you got, I think,
Yeah,
4.
four in west and
about
6 in
6
east.
And then you have about, one of those beds, you really want to have a special bed, meaning that they can lift up individuals over a certain weight. The special beds cost about $11,000 a piece. And then the regular beds cost about $2,000 a piece. And so we decided, you know, some thoughts, you know, let's work on this on a quarterly basis, you know, maybe get 2 at one time, you know, begin to build it like that.
Okay.
For the clinic
It's
personnel.
not exciting to you all like the ambulances, but it's exciting to me.
Yeah.
Well, when you go in,
yeah,
you know, and then we also, you know, we had some,
Right.
we
little
also
things.
had, some individuals reached out to us about that too. You know, maybe want to help us get that, so just want to put that out there.
That's good. Well,
But
that
that's
was
what we
easy.
said.
I wanted a trip to Cabo with 2 or 3 fishing, about a 10-day trip to Cabo with 2 or 3
didn't think
fishing
quick enough.
trips in it. That was good.
Okay, thank you.
Thank you,
Thank
Susie.
you.
Thank you,
Yeah,
Susie.
Susie's doing a great job too,
She
really.
does a great job.
Okay, next item is Mr. Gibson, plant operations.
Yeah, Craig, he has 2 interviews he's doing this morning, so I told him, no, you don't have to worry about jumping in. But one of the things we're doing, you know, he mentioned before, we started putting down flooring in the ED, already have the flooring in there, new flooring. We have flooring in the front office of the hospital. We have flooring down the patient wing, the new flooring there. It looks very good. We're looking to do the rooms. And then for the CT project, he told you about that, you know, with the generator, you know, that's kind of like a work in progress with that. But he had a maintenance staff leave, so he's interviewing this morning for, I think, could be maintenance or housekeeping, you know, two or three positions this morning he's interviewing for right now.
Housekeeping is a constant turnover, isn't it?
Yeah.
In every hospital,
Yeah.
not just ours.
What do you do? How do we do something about that?
We can't.
I don't know. It's kind of hard here because,
It's every hospital, it's
It's a
not just
tough
ours.
job.
Let's don't say it's everybody.
It is
Let's
everybody,
tackle
Duffy.
it. Okay, well, let's make it everybody but us.
yeah, it's kind
Let's
of,
think about what we can do about that.
Yeah.
I've heard this. We got our plant operations manager cleaning up rooms. There's nothing wrong with that.
Yeah.
Don't get me wrong. And Craig takes it and runs with it. But let's just do some thought, do some brainstorming.
yeah. It is.
And, you know, that's all I know to say, you know.
Well.
I agree that it's everybody, but
I mean,
somebody's not having
Well,
problems.
you know, I don't know. I mean, we have somebody here now that's leaving, moving out of state.
Well, I understand that. I'm
You
not,
know,
I'm not blaming anybody.
yeah.
But if it's a matter of pay, let's look at the
Yeah, we look
pay,
at-
or, you know,
yeah.
what we need to do, because it tends to drag your whole operations down when you're pulling people from other places to do that. And it's one of the most important jobs we have here, keeping them rooms clean. So let's give some thought, and I'd like to ask the board members to.
Well, I think one thing you, I don't know if you want to go down this road, but you could outsource it to a vendor rather than doing it and trying to put
That's what I was
the
just thinking.
employees to yourself, so.
That's what I was just thinking.
Yeah, you know, maybe there's a vendor, a company that does cleaning, and that would, we could pay them to do that rather than, you know,
Good idea.
have the employees under our.
Another thing
I
too
would-
is when I was doing it before Craig came back, I was overseeing it. A thought I had, which is a pricey cost, is to outsource all your linens. So then when you do just have a few staff members, they can stay inside the walls of the hospital, moving, you know, and they're cleaning and stuff. So you're not working them, they're not running outside doing laundry, coming back and all this. You just take the laundry out of the equation altogether. And I got a quote for it back then, and it wasn't cheap.
No, I bet.
But, you know, I mean, it's an option, even if you're down to just a couple staff members, which we always are in that department. At least you're not running them ragged, and they're able to maintain the interior of the hospital a little bit better.
Yeah.
Or you
Well, I'm-
go to the 1984 George Orwell model. Okay?
What is that, robots or
No,
hypnotize people?
that's, the dirty jobs get the highest pay.
Oh, okay.
Well,
Nurses
I'm not
clean
wrong.
poop all the time.
All
I
the
knew that.
time.
I'm just saying.
And if I remember correctly,
I'm just saying.
and we've done our share of housekeeping as nurses
Thank
too. When I
you.
worked at
Yeah.
TMH, we would have to leave the ER and run upstairs to clean beds because we were short housekeeping.
See,
That's
that's
the
not-
truth.
Nurses in the ER
That is
flip
a-
every single
Yes,
room.
they do.
Every time a patient
Yes,
leaves,
they
the
do.
nurses flip the rooms in
Yes,
the
they
ER
do.
unless it was like a COVID or it needs a deep clean.
And I
Right.
think,
Well, let's,
Well,
I'm gonna ask everybody on the board to brainstorm, ask y'all.
yeah, I'll
David, you
talk.
got other hospitals, see what they're paying, see what and if, I understand it is with a lot of places.
Well, David, you could probably let us know, Mr. Bowen, whether the other hospitals are using outsourcing that particular with a vendor, whether there are any vendors. I don't know about down here, but, you know, a lot of restaurants used to, that I know up north, would send out their linens and tablecloths and linens to a facility that did all that. I know down here that the Gibson has their own facility, which is over there by Ace. That's where they're doing all their linens and laundry. So maybe there is a company that we could outsource some of that, either the linens and or the you know, the actual cleaning of the building. So
And the Gibson might have some excess capacity. that
You're right.
needs to
But they
be
might
used
outsource
up.
it, they might take it and outsource it.
well, no, I know they do it themselves.
But I'm talking about they would be our out,
Well, yeah.
they
Yeah.
would, they would.
If they wanted to do it for us and we, you know, get a fee
Paid.
for it.
Yeah.
Yeah, excess capacity.
Just some
It'd
thoughts.
be a good community service for the Gibson just to do that for us.
Yeah, good luck with that.
Yeah,
They
I don't
don't
think
do
so.
it.
I know, I don't think so.
Let me know how
David.
that works out for you, Duffy.
Okay, y'all, we've got a situation
What I do.
that we don't need to just say
Yep.
it can't be done.
No, we'll bring Craig in the conversation because he's done some research on this. And what we'll do,
Okay.
we'll look at, you know, outsourcing with a vendor, you know, as well as, you know, different things that we can do to, you know, with housekeeping staff. Now, to be honest with you, I don't want to go down that road.
Go.
No. And the reason why I say that, because you look at, you know, a lot of hospitals, you know, we look at outsourcing a lot of different things, really, and not only housekeeping. You know, they do a lot of
You know,
different
I'm just
stuff. But I
saying.
don't want to go down that road with that.
Okay, that's fine with me, but
Not right now.
let's see what we can do about that, you know?
Yeah, we can bring that back. I mean, like
It's our job to
Zestri-
solve
Bill
problems.
even mentioned, I mean, we have, we have hospitals that do outsource it, we have hospitals that do internal. I mean, so there are different models. I think what David just outlined is what we'd like to bring back is look at our situation here, look at other locations and what they're doing and do some comparable
Okay.
models there and see what makes sense
Good.
for here.
And David, can you all hear me?
Yes.
I just wanted to make a comment. As David mentioned, we just recently had one or two of our other hospitals just convert to outsourcing because not only is it a personnel thing, you have an equipment issue. And, one of the things that you have to really be careful when you're talking about, doing your own laundry and linen. There are standards of how high that temperature has to be, for your wash and your dry and all the infection control aspects of it. You don't see many hospitals nowadays continuing to do their laundry and linen in-house just because the cost of the equipment that you need to replace, because that stuff wears out because you're constantly using demand. So as David mentioned, we have a number of our facilities that are outsourcing it right now. And we certainly can bring back some, some feedback and some information on the cost that, they're incurring and how the process works. So happy to help y'all with that.
Okay. Thank you. All righty. I didn't realize that. Anything else from Craig you want to talk
I
about?
think we're good. You want to do a break, Dr.?
Yeah, let's do a quick break, 5 minutes. The mics are hot, I guess. I don't know how you. The next item is the CFO report. Mr. Bowling?
Yeah, you can. Just turn the mic on and off? Okay. When you want to do that?
Next time.
So, what happened to Mr. Kosar?
Marone, is it ready to go?
Yes, sir. Do you need to share anything?
No.
Okay.
I just
But yeah, you guys are recording and you're.
getting my notes, getting my notes ready. Just make sure.
Are you gonna be in after our meeting? At least you about 1 minute. All right, David, you ready? Are we ready? Everybody ready?
Yeah, I think so. I think we're ready. Just trying to get the notes pulled up here since. All right. So, obviously we're into the new fiscal year for the Weems Hospital. This is the fiscal year 2026 period that we're starting. This is the first month of the hospital's new fiscal year, so I'm going to speak about the financial results for the month of October. We're looking at October. The consolidated net income did finish at a loss of $42,000. That is compared to a budgeted loss of $116,000. Looking at October's performance, some key drivers that I want to mention to the board and mention to everyone. Looking at gross patient revenue, starting at the top of the income statement, kind of walking down. Looking at gross patient revenue, we did finish just under $116,000, or approximately 6% versus what we had budgeted. The drivers behind that decline in revenues versus what we had budgeted was primarily with total patient days being down approximately 13% versus what we had budgeted. That did represent a decline in revenues of approximately $171,000 within our inpatient activity. Again, this is compared to budget. That does include swing bed activity for the month being down as well. And recall that one of our strategies, and it continues to be a strategy though for this organization, is to enhance and grow our swing bed program. We took an aggressive approach within the budget to load those additional days, to challenge ourselves to find more swing bed related patients, and we're going to continue to do so. Looking at the hospital's overall though average daily census, and I always like to point this out, when you look at inpatient, swing, and observation related patients, so patients that are in the house on a daily basis, we did finish at approximately 2.5 patients in-house. That is up from where we were running in the previous years, but it is, again, less than what we had budgeted. We had budgeted around 2.7, so we did finish slightly below that from a daily census standpoint. However, though, outpatient revenues, outpatient was up about $54,000 versus what we had budgeted. Outpatient does include ER activity. When you look at the ER service line alone, our ER visits were down 73 visits, or approximately 17% versus what we had budgeted. And I do want to point out, and this was mentioned earlier when we were talking about the ER providers, we have begun charging for the ER providers' professional services in the past. Obviously, that was handled by the previous group. Now that those providers are on staff with us, per se, we are charging and billing for their services. You do see that reflected within the revenues. Our ER visits, though, did finish October at 352 visits. That is down, as I said, versus budget, but it's also down compared to our trailing 12-month run rate. We have been running about 395 visits on average over the past 12 months, so October did see a decline. With that lesser ER related activity, ancillary related services, labs, pharmaceuticals, and so forth were down. Did see some declines within our radiology exams as well. But as I pointed out, overall outpatient combined was up. And a driver within that is our outpatient visits outside of our ER. We're up about 3% versus what we had budgeted or finished at 306 visits. Again, that is up compared to our trailing 12-month run rate, which is running around 279. So our outpatient-related activity did increase for the month of October. That increase, when you look at the chronic care management program, was a driver for the month of October. Our chronic care management program did finish at approximately 171 visits, which is compared again to that trailing 12-month run rate of 148. So we did see an increase and a spike within our chronic care, again contributing to that outpatient growth. The clinics, as Susie just spoke about earlier as well, the rural health clinics combined, the two clinics, they did exceed budget by $25,000 with the clinic visits finishing up 2% versus budget versus the budget. They did finish combined at 647 visits, which again, and I do these comparisons to our trailing 12-month to see how we have been running. They did finish combined at 647, which is up versus our trailing 12-month of around 558. So we are outperforming how we've been running and continue to outperform prior year. And I think you can see within the key performance indicators, you can see that continued year over year over year over year, 4-year trend of improvement within the clinic growth.
Yeah,
so
great.
yeah, it's good, really encouraging to see that within our clinics. And you spoke about this earlier, and Chris, I know we did meet with the providers. I think was well received. That incentive program is in effect with them for them now. We did date that from October 1st forward, so that we're into the current fiscal year. So they are. We explained the process to them, so we'll continue to work with them and educate them as they move forward. But they seem to be well pleased with that, and wanted to say thank you to the board for their decision to offer that to them. EMS, and Jane spoke about this, but EMS from a financial standpoint, you see that within the packet of information that was provided, EMS revenues were down 25,000. Billable runs were at 93, which is primarily flat versus the same period in the prior year. But again, compared to that trailing 12-month, that run rate, it's down as well. We've been averaging, or EMS has been averaging about 105 runs. They finished October at 93, which contributed to that decline in revenues. Net patient revenue, again, how's this revenue going to translate into the cash we expect to receive? Net patient revenue did finish down 74,000 or 8% versus budget. Again, that primary driver in declines in what we would anticipate collecting is related to those declines in inpatient activity. Inpatient activity is a higher reimbursed or higher acute related service. When those are down, outpatient up, your expected collections is going to be down as well.
But one thing I want to point out here is that our gross patient revenue, even with the negatives in this in the categories between inpatient and ambulance, we're still at almost 91,000 above prior month.
Yeah,
looking at the prior year's month.
Same period in the prior year. Absolutely. And the reason why I'm mentioning versus budget, because as I stated earlier, we took an aggressive approach within our budget to target swing bed growth. And again, that continues to be a strategy. It's going to be a focused strategy here. We did see declines versus what we had budgeted for swing bed. But to your point, though, it is continuing to outperform the prior year related overall revenues.
Right. I mean, your budget's just a crystal ball figuring out what might happen, but what's really happening is we're doing better than we did last October.
Sure. And that's why, and I'm glad you're pointing that out, because that's why, when I'm doing these comparisons, I'm talking about versus our trailing 12-month run rate, I'm talking about how we're currently running and have been running and where we're performing at today.
Yeah, let me just mention also, David, if you look at, we're talking about swing bed days, October we had 48 swing bed days. That's probably the highest we've had besides September of this year than we ever had the whole year. So the swing bed days are high. Yeah. Just the swing bed admissions was low.
Right. And we're going to continue to grow that because that's going to be a good.
So why is the in-bed patient down from prior year or month, 52, almost 53,000? If swing beds are up, so what's the driver that's bringing that down?
Well, when you look at year over year, like you just stated, I mean, our patient days, and I just pulled that up, patient days are up 27%. That's why you're seeing that increase year over year in revenues. But in the budget, you know, we are down combined 17%. Okay, because the budget, although we finished 48 days for swing bed in the month of October, which is, as David pointed out, is a good month, we had a budgeted target of 59 days. So we were down compared to budget those additional days that we had put and built revenue around.
I'm just looking at October 2024 versus October 2025.
Are you talking about budget, or are you talking?
No,
about
I'm talking about actual.
Actual, yeah.
That's what I'm talking about.
David's talking budget.
I know, and I'm talking actual.
Didn't we have a patient,
Yeah.
a female patient that was on bringing in a lot of revenue about this time last year?
Yeah,
That would have
I'm
thrown
trying to
this thing
recall,
out,
but-
if I'm not mistaken. I may be
Yeah.
wrong, but I thought we had
Yeah.
somebody.
We did have
Yeah,
somebody
Courtney,
there
yeah.
about, I guess it was about this time last year that was there for an extended time.
Extensive service.
Yes.
And they left,
Yeah.
just cold turkey, and
Yeah, we had to
Yeah.
remember that. Yep.
So
I
that
don't know
Octo-
if that's the explanation,
Yeah,
but
Yeah.
so that October number was inflated because of that one patient that was here for.
Possibly, I really don't
extended
remember the
period of time.
dates exactly,
Yeah.
but I remember the patient I think
Yeah.
we're referring to.
Okay.
I'd have to look into those dates exactly.
Yeah, to see how that overlapped, Bill, to see what.
that's what
period.
really highlighted the swing bed issue.
Yeah,
And as far as how important it was, as far as I'm concerned.
sure.
And I'll go from there.
I will say we have 3 now and all projected to be there through December 11th,
Got
December.
3 swings.
So,
Yeah, and I was just looking at, if you look at the stats for the whole year, last year, then October, the highest number we had prior to September of last fiscal year was like 43 swing bed days, in March and in June. And then September, we had 48 swing bed days. October, we had 48. So 48 is kind of like our top number we're hitting, which is a lot there. Although we budgeted for something a little bigger than that.
You know,
Well,
I think
September-
what you
September
can
not-
do
yeah.
when you're figuring out a budget, you can budget on the low end and pat yourself on the back that you came in over
Right.
budget as far as revenues, or you can make the budget your goals and possibly, and I'd rather go the other way, even if you not too much.
Mm-hmm.
But we don't, I'd rather be thinking we're struggling a little bit and keep working hard at it than run around and pat ourselves on the back because we exceeded revenues on the budget. And I think that's a good take on that.
Sure.
Just
Yeah.
my
So,
own thought.
addressing that same issue is, I had a conversation with David in the beginning about budgeting, and that, he made it tough on us, okay?
Okay?
He wasn't easy on his budget. We would have had to have reached pretty hard to get to his numbers, budgeted numbers last year.
Okay, well, that's
Yeah.
good.
Yeah.
I'm glad
Yeah.
to hear that, but that's good. That's the way I think we should be right there.
Well, we're going to set targets, reasonable targets. I mean, targets and goals, and look for this community to be able to
Yeah.
deliver the services that we feel they can
Sure.
execute on. So we got strategies, we got plans in place, but again, and I'm glad David mentioned that. I'm glad we're having that discussion
Yeah.
about swing bed, because if you look at September and October, that is the 2 highest months in the past 12 months. But yeah, we missed budget.
Yeah,
So
we-
it is good to see that is growing.
Yeah, because if you look at, the direction of swing beds, probably about 2 years ago, we were kind of low. And then we just stopped. We went way up, really. And then as we began to do the budget, we still was going up. And that's when the conversations come in and say, well, maybe we need to be, maybe come back down a little bit. And so that's where we at right now, which is good,
And you also spread your amortization out more evenly across the whole year, if I'm not mistaken, which should have affected our numbers. The one thing I'd like to ask about, who is now the lead on the swing bed? You still doing it? Okay. I think we ought to consider, and maybe this ain't the right thing to do, but that swing bed is such a vital program to us that maybe there ought to be some incentives added to that. The more you bring in, you're going to get a little piece of the action type thing. You follow me?
Yep, commission.
Yeah. Well, I don't want to call it that. Finder's
That's what it
fee,
is.
commission, whatever you want to call it. But I just think you get good swing bed numbers and you're putting $2,000 a day ka-ching in that machine.
Well, or you have somebody who's dedicated to do it, rather than have Courtney trying to wear
Right.
To do all
15 hats.
everything.
You have somebody that's dedicated
Well,
to
she
it
had
like
a
we did for a
coordinator.
while, you know.
Had one, didn't
Yeah.
you?
And Courtney can tell you, you can tell them the plan, we're still trying.
Yeah, so we had a coordinator, and originally it was a part-time position, and then we moved it to a full-time position because that was what that person wanted. And and then that person left, and so I'm trying to tweak that job description and make sure it's the right fit for us, because currently it's not a full-time position, in my opinion, but with them taking...
What is that?
I don't
Oh,
know.
my God.
Y'all, I'm sorry. I
Was that
don't.
your cat?
John, you okay?
Cut my phone off. I don't know how that works.
Halloween's over, Duffy.
My granddaughter had this the other night, well, not before last, she said, I got some surprises for you, Pop.
Oh,
Thanks a lot.
Thank you
You
very
can
much.
tell her about this now.
She didn't tell a lie, did she?
So anyway, still building that job description, but we're outsourcing, like I've said before, the nurses. If our census is low, I'm sending them to these things, and I'm going to Tallahassee myself for these meetings and stuff as well. So yes, it would be great to have somebody else to do that, but I'd like them to do that along with be our outpatient nurse, along with other things that I
Yeah.
think would better utilize our services and their
Yeah.
time as well.
Make it a full-time
Yeah.
position.
And continue to make it a full-time position, because the thing is, you pay somebody to be there full-time and you don't get any referrals, there's only so much you can do.
Right.
I was hustling last week for 2.5 days to get these 3 here that we have now, and I didn't get to do a whole lot more Thursday
Yeah.
and Friday, but the rest of the week I didn't have any activity, you know?
Yeah,
So-
but I think what we talked about before with this is that there's a lot of different people involved in making those referrals, so we need somebody in their face on a regular basis. And you said the referral people change
Oh,
quite often.
constantly.
So therefore, we need to have somebody who knows who these people are, who know who the changes are, and to continue to be in their face, and like you said, bring them donuts or whatever it is that is going to motivate them to pass the list of people off to us.
Yes,
right?
and I just went to TMH and Lori with Alliant hosted last month, a lunch and learn, and all of case management came in and Alliant fed them, and we were all there from our hospitals and talked to these people. But again, if she did it again in 2 months,
Sure.
I'm not going to see any
Yeah.
they can't help it. It's just the turnover. But it's also the distance from those facilities. But one of these patients that we currently have had a procedure at Tallahassee within the month, and then the spouse called me and said, I had no idea this was even an option when we had that last time. Because the
That's the problem,
hospital
right?
didn't
That's
send
the
them,
problem.
Yeah, it is the
didn't
problem.
tell them the information.
That-
But I
yeah,
mean, we
that case
can't live there.
manager- the
But you
case
can go to
manager.
TMH, and
Do we
there's
have pamphlets that explain our swing bed?
yeah,
Yes,
and we
ma'am.
take them, and I mail them, and Brittany takes them, along
Uh-huh.
with goodies, and Dan used to take them and all that.
Yeah.
But still, it's just, they've got to have us in their brain all the time. And people
Yeah.
like Encompass sit in their lobbies and wait on referrals, stuff like
exactly.
that, you
It's
know,
gotta be-
because they're right
Yeah,
there.
it's got to
They
be
have a
continuous,
lot of
that's
high
right.
turnover in that area.
Yeah.
Yes.
If I recall what you
I think
told me.
that they do, yes. So, I mean,
And I guarantee you, their job is to get them in a facility, get them out of the hospital, get them in a facility. And
sure.
as
And then
quick
they
as
don't
can.
care where they go, and I don't blame them. They just, they're doing their job by getting them
Right.
out of that bed so they can put
Right.
somebody else in it.
Right.
So you can't fault them for that, but, you know, how
know,
much
our-
can we really have somebody in their face? We can't house somebody in all those facilities all the time. So we'll continue to be creative about it and do what we can and mail them stuff and send nurses when I can, or I'll go to these meetings. Lori is a big communicator between the facilities and us because she communicates with these facilities and visits them herself, and she takes
Okay.
our stuff as well, and she hosts these things. So, I mean, she is our inside hand for sure with TMH and the other facilities as well.
And we still want to hire, we're still looking to hire somebody for
Yes.
that position.
But you're working on the job
Yeah,
description.
yeah, and I know that initially when Court and I first started talking about this particular position, we did think about adding a commission to it. Meaning that if you got 2 patients in, you get this amount. You
Yes.
know, something like that. You know, we had that conversation.
We did.
You know, for if we were going to bring in another person. So these are some things that we can discuss. But our main focus also is to look at our ED patients that can be swung. That they come in for inpatient and then we move them to the swing bed area. That's the focus that we got to focus on, and which we're doing. But that's one of the main focus also, because we look at a lot of patients that we probably can go for inpatient stay, then the physician may say, okay, let's go ahead and see if we can swing this person for inpatient rehab. So we got to make sure we focus on that as well.
Court, does Lori liaison between Gulf Coast and Bay as well, or is she just primarily
does.
Tallahassee?
She does, the Gulf Coast and Bay as well. She visits those facilities, and then she'll contact me, or if I contact her and say, hey, we've got this one we transferred out, she'll follow up on them. She's got good working relationships with all. I believe I'm correct in saying her strongest relationship is with TMH. She also has access to their system, their
Okay, that
EMR,
helps.
so it helps.
Kristen,
because
we're working on that, because,
Yeah.
Lori's a resource that we allocate out, and we're looking to take those opportunities to get her connected with these other.
With Gulf Coast
Yeah,
or
yeah,
HCA?
TMH,
Yeah.
as Courtney just mentioned, I mean, she's connected there because she gets access into their system. We've been able to work with them to do
Who does
that.
Lori work for?
Alliant.
She's with us. yeah.
Alliant.
She's a
Okay.
great resource.
Is there a service by a knowledgeable person that provides the information for swing beds as those that provide access, takes you around and shows you the different rehab centers or the rehab locations, that's their sole job? That they're probably part-time, they're self-employed, and they get hold of you and then they take you to different facilities. Is there some service like that out there?
John, I don't know of one service out there. As been outlined, the inpatient rehab is a very competitive business.
Yes, it is.
You have the for-profit companies like Encompass and some of the others that are vying for those patients also. So, but to answer your question, I'm not aware of a service like, and I know they do those with nursing homes, for nursing home placements. It's a thought, but, as outlined before with Lori Franklin, in the last few months, she's really stepped up her efforts with the Gulf Coast and Bay, to really start making inroads into those programs, to be able to try to get those referrals back. But to answer your question, I'm not aware of a service that would enable patients to be able to determine or help them select a swing bed or inpatient rehab program out there.
And Lori was the young lady that was at the foundation event at the table. I think it's kind of most of y'all met her who were there at that event.
Yeah.
Yeah, okay.
Okay. Well,
Thank
just-
you.
Just jumping back on the financials, just kind of finishing up a few comments here, but, looking at the expense, just kind of moving down continuing to move down the income statement. Signed out for a minute. Some notes on the operating expenses, just to highlight a few areas there. Even though revenues, again, and I'm speaking against budget, obviously, but when you look at operating expenses as well, total hospital operating expenses, we finished down approximately 153,000, or that's about 13% versus budget. And personnel costs, again, the salaries, wages, benefits, and any type of premium labor. When you look at that, all those categories combined, that's our biggest spend. But you look at those categories combined, we were down slightly versus our budget. Obviously management, the team here has continued to focus on daily productivity. They have a daily productivity and a biweekly tool that they do monitor and review, and does get circulated, which I think has been very, very beneficial and helpful to help monitor and control that. Professional fees were below budget, approximately 32,000. Now within that particular category, that is where we have historically, recorded the ER providers. And we will continue recording the ER providers now that they are, under contract with us. But we also, in the budget, we did have some additional dollars that we had put in there. Again, as we challenged ourselves, like we mentioned earlier around swing bed activity, we did challenge ourselves with more swing bed activity, which means more fees that we do have to pay out for therapy-related services and so forth that we are contracted with. So with those days being under budget, revenue under budget, those expenditures associated with that were also under budget. When you look at supplies did finish below budget as well, about 63,000. The main driver, some volumes were down as I've been talking about, but also within the supply category, we did build in that reserve that we had set aside for the retail pharmacy and the startup of the retail pharmacy. I think all remember during the budget process, we did go ahead and put the retail pharmacy in the budget, with the startup costs associated with that and then a ramp up throughout the year. David mentioned this earlier, but I'll go ahead and bring it back up. We are, revamping that previous pro forma that was built around the retail pharmacy. What the data that we're, waiting and trying to get a better understanding on. Some of that information, the costs, the salaries, the capital, those numbers won't change as much because this information was pulled about 2 years ago, a little over 2 years ago. But what will change is the script capture, and that's what they're trying to, prescription capture, and that's what they're trying to get their hands around to get a better understanding of that. Reason I'm bringing that up, I just mentioned how the clinics have increased their volume, so more prescriptions have been generated and are being generated throughout the community. They want to get a more accurate number than what we had 2 to 3 years ago, really 3 years ago. So they're trying to get their hands around a more accurate number so they can forecast that, give us a better picture.
I think your construction costs have also gone up significantly, and you have to look at that.
That's a great point, but again, the building's there. It's just going to be some internal structure as well, but that's a great point. That will be, again, they're revisiting all the numbers associated with that.
You look at the cost of a 2x4 today from what it was 3 years ago, it's ridiculously costly.
Hey, easy.
Right. Somebody's making a lot of money on it.
Easy on the lumber.
Somebody's making a lot of money on it, but I don't know.
Easy, boss.
Well, I guess Christy
She's not sick anymore. No.
well, I guess Christy can give us an estimate.
Today's hardware get thrown in the middle.
we know someone. Well, but that's but that should be. I know we're not meeting in December. The team was going to chime in this morning and just give everyone an update. I told them don't. I mean, if you wanted to speak to them, it'd been great, but they didn't really have anything else to share other than they're trying to capture and get better information on the actual prescriptions now that are being generated within the community with our clinic activity increasing. But that should be ready to go and ready to be shared at the January meeting here for the board, hospital board, and as David outlined, we would anticipate taking that forward to the county commissioners as well and providing that update. Again, just in summary, October's month end did finish the consolidated net loss of $42,000 versus a budgeted net loss of $116,000. So it did exceed budget by approximately $74,000. So our loss did decrease versus what we did have budgeted.
Yeah, don't say exceed because you did decrease the loss.
Decrease the loss. That's correct.
Okay.
That is correct.
Go ahead.
Oh, I'm sorry. If you have a question, John.
I will in a second.
Okay. Just going to make some balance sheet cash flow related comments too in closing. But again, the overall cash position for the hospital does continue to be steady. Our cash days on hand did finish at approximately 77. That is up from 60 days, about 60 days in the previous month. Patient AR, accounts receivables, obviously, always a focus point, for the facility. Did finish October at 72 days. When you compare that versus that trailing 12-month run rate, the run rate has been 78 days, so we did finish at 72, so there's an improvement in the overall AR collections. Again, cash steady, days on hand up as well versus previous month. From an AR standpoint, I know the team here obviously stays very involved with TrueBridge, the third party that does process all the patient AR for the hospital, so they're staying actively involved with them. We have also included in the board packet, it's a lot of granular related information, but it is a revenue cycle dashboard that we are rolling out that does have a lot of KPIs in it as well. You do see that in your packet, and that'll help all of us actually effectively monitor the targeted goals and so forth we have for the facility, and again, help us to identify ways to achieve best practice. Within, and I've said this in several meetings just to bring clarity around some of those numbers. There are some moving pieces with DISH, LIP in the balance sheet. I know the auditor, typically discusses that with the board and the county as well. Those values are still in there, but it does include, the 1.3 million for DISH LIP receivables. Speaking of the audit, since I just mentioned that, I know the 2024 financial audit is underway with Carr, Riggs, and Ingram. I'm sorry, the fiscal year 2025 financial audit is underway with Carr, Riggs, and Ingram, and they are working on that and have been working with the team on collecting the data and information and getting started with that audit process. So once his Carr, Riggs, Brian Hall and his team complete that, obviously they'll come back before the hospital board and the county to share those results. But
I got a question there.
Yes, sir.
What we've been doing with the IT, are we going to clear that standard, you think, or are we still a little premature? We're going to be right in the middle of it. We probably.
I think some of the steps we've obviously addressed.
Right.
I haven't heard officially from the auditor.
Okay,
I know he's going to look at what has been done.
I
I think with what has been done, it may meet
standards.
their standards, but obviously there's additional work that's
Right,
taking
okay.
place.
You're talking about where we got dinged on it? And
Yeah.
This will knock it off, that note off? I
Maybe.
think- Yeah.
Yeah, it should. Again, I'm not going to speak for the
Oh, I understand. You
firm,
can't
but I
speak
do
for
feel like that we did meet what they had identified in their review process. I don't know if there'll be additional, but I do think we met what was requested.
How often do you write off your take your bad debts off? In other words, hit your allowance. The reason I ask the question, so I don't set you up too bad, is I see the 544 in September under bad debt. You cut that well in half, okay? You got to, go ahead. It's on your revenue cycle dashboards where I'm looking. 544 for 9/30, and 219 for 10/31. You drop that bad debt, you drop the bad debts,
Sure.
cut it? Okay. Now, if you look at that, and then you come along and say, okay, what is that bad net percentage? It's 21. You come on down, and if I did this correctly, I'm looking at the credit balances. You drop the credit balances down, those being outstanding, but yet you drove your AR days up. You follow me?
Sort of.
Okay.
Yeah. So again, let me try to step into each of those, because it's all can be related, but it is. Let me just try to describe that. Bad debts typically includes two things. One is obviously the bad debt actual adjustments that take place on a patient's account once it's deemed uncollectible, and then that account is so once the team has gone through the process and been turned over to an agency on collection of that, and that is deemed uncollectible, truly uncollectible, that's a true adjustment that takes place. That's part of that. Secondly, inside of that is what's called a bad debt allowance, where you allow for doubtful accounts, and that's assuming that and that's based on historical a historical look back. Again, not to go too far into the weeds, but there is a hindsight review that says historically 93%, I'm using this as an example, 93% of a self-pay related or private pay related activity is uncollectible. And so that is allowed for as a potential bad debt. That's part of that. So you got an allowance and you got an actual adjustment. And that allowance does change as those accounts are then moved out into actual adjustments. So
When you write them off.
that absolutely correct. And then kind of moving and explaining, credit balances. Again, credit balances. Again, whether it's whether there's been an overpayment and or an over adjustment that has generated that actual credit. Those have to be actually worked through patient by patient account to determine where is that true credit. Is it patient responsibility, or was it an over adjustment and or was it overpaid potentially? So those have to be worked account by account. Those are in your receivables, which again, if that number is, again, it's in your receivables as a credit, right? So it reduces that overall value. So, and then certainly, John, the last part of that, when you look at AR days, that is a computation of receivables over a denominator. That denominator typically is the average net over the previous 90 days. So
you write off, or you reduce your receivables, okay?
mhm.
And then all of a sudden, your outstanding credit balance is increasing, right? Isn't that what that's telling me?
Probably have to take it offline or
Yeah, okay.
or walk through it
That's
with you, because
fine.
I'm not really sure I'm truly following. But credit balances are there. I mean, if they decrease, then you're removing the credit balance on the patient's account, and then
Right.
your overall receivables will increase in that situation.
So the logic behind it is that if you take a bad debt out,
Mhm.
okay, the credit balance, because it's no longer collectible, you take it and you drive it down,
Mhm.
which it appears that's what
Your
occurred.
days will go up.
Then your days should go down too, because you took all the bad ones out, right?
No, the credit reduces that overall, right? So if you take credit out, your gross AR is going to be higher. So your computational days will be higher.
Okay, we'll take it offline. Now you throw me a curveball.
But yeah, no, I
Did you
love
understand
it.
That
But-
curveball came back to you.
Yeah,
Yeah, because I don't understand how you take all the bad debts out of the receivables, in which had
Yeah.
all that long history of
Yeah.
days being sitting in there, and you take them out, the
you're-
number of days outstanding should have shrunk.
Yeah, but you're taking some of them out ahead of time, right? I mean, you're taking them out in advance, an estimate in advance, right? Isn't that what
Yeah.
we're doing? We're
No,
estimating.
that's not what I.
well, you got two things in bad debt. One is actual, and one is
Actual, that's where
one
I-
does include.
One
that.
is estimated, one is actual.
That's right, and both are in your bad debt, right? Because you gotta allow for bad debt on an estimate, and you got an actual. But I think it'll help you, and I'm glad you're pointing this out. Though. I know we're diving into weeds, but the point of that dashboard, again, is to have KPIs that we can effectively monitor and look at best practices for revenue cycle, because we want it to be hitting where we're targeting these goals. And so I appreciate you asking these questions, because it means you're actually looking at that information with us as well.
Well,
And
that
that'll
also
help.
tells me how well you budgeted,
Yeah.
okay?
Yep. Okay.
Thank you.
Yeah. No, thank you for asking those questions. When you look at, again, just continuing on the balance sheet there and just talking about some additional cash-related questions. Cash going out the door, our payables continue to be there's no vendor payables, and I always like to point that out to the board as well. No vendor payables, no, or I shouldn't say vendor payables, but no vendors at risk. Vendor payables are continuing to be managed appropriately. Our vendor payables are around 500,000 outstanding balance currently. That is a very manageable number here for this organization. I do think the creation or the startup of this revenue cycle, or not revenue cycle, but this finance committee that's meeting twice a month like this has been extremely beneficial, because again, it gives the board and others a chance to be able to see what's truly in payables. It brings that transparency around it. That way you can see that overall number as well, and you see what's there. So I think that has been very helpful, and I appreciate you guys certainly participating and helping with that as well. It's been a very helpful process. And again, it's a best practice process, actually. Just looking at other organizations, and I've discussed this and shared with others, right? I mean, this is a best practice for the board to be involved to help see and bring some transparency around that. When you look at again some other current related liability activity, and again I'll close with that, but again it continues to have the real capital improvement dollars that we have in place. I know a lot of these dollars, you'll see some of the movement of these dollars come out of those liabilities once this CT and renovations and everything takes place. We'll see movement, because at that point you can recognize that into income, whereas it's sitting on the books right now as a liability. But again, we'll work through that process. You'll see some moving numbers there as we work through this renovation project with the CT.
Dave, I have one quick question, just
Yes, sir.
just for my edification. Under the liabilities, you got long-term pharmacy lease at a negative. Is that because we prepaid it?
Yeah. You're looking at the...
I'm looking at the balance sheet.
Yeah. Yeah, and Bill, that's a new accounting standard that's in place that, again, I don't have it pulled up on my screen. I'm trying to look over at it. But again, the new accounting standards that were put into place, GASB standards, that were, I believe, recorded last year, at the end of the last year, through the audit process, where you do recognize the value of, again, I'm assuming that is our pharmacy related equipment that we have through a capital lease approach, or capital lease that we have established with them. There's a current and a long-term portion of that, right? Because the current portion is going to be what's in that current 12-month period. The long-term portion is going to be what's still outstanding in that lease over the more than 12-month period. So there was some movement and true-up of that activity related after the audit process, which was a new standard that had to be put into place. I think I said that.
So it's an adjustment, basically.
It's basically to balance out the monthly expenditure, I call it monthly allocations, so that it doesn't get you like we saw before. At the end of the year, we see all these numbers going, wow. Now they're just smoothing it out. You got a current and you got a long-term responsibility under those leases.
That's, I mean, that's, in a nutshell, that is part.
I just wondered why you had a negative under liability.
Yeah.
Please. All right, thank you.
Yep. But the other thing I want to mention too, before I do close, we talked about EMS, but again, you see the financial statements in the board packet. We do continue to break out the EMS again for the board and for the county's purposes. The EMS gross margin, I talked about that earlier, but when you look at revenues, I mentioned that earlier as well, being below budget. But I think a good comment was what James had mentioned there earlier too. When you look at their overall margin, right, the primary, you did see, although revenues were down, expenses were down 16,000 or roughly 8%. That primary driver within their total operating expenses within EMS was a decrease in wages. And that means, although he mentioned overtime month over month, when you look at how effectively they're managing the EMS today, they did see wages down about 13,000 or 8% versus budget, which is down also compared to last year at this same time of about 3,000 or 2% drop. So I think, as David mentioned about James and his leadership and so forth. I think they're doing a really good job. They're working obviously very diligently to monitor staffing and fill their staffing gaps. But I wanted to make that comment because I know it's been a discussion point throughout the past several months about EMS and their operations. But to see their expenses down 16% or 16,000 versus budget, and down 3,000 versus the same period in the prior year, with the driver being related to personnel costs being down, that was good to see.
Well,
within EMS.
it's a fact of being fully staffed rather than having to pay the OT.
You don't have the premium labor.
That's part
correct.
of it.
That's part of it. That's part of it.
Part of it.
Yep.
The other part is how many, and I don't see that in these financials, and it's not something that you would see otherwise, but how much relief on the financial burden are we getting from the use of helicopters as opposed to sending our ambulances out of county?
That's a good question. I don't know if I have. Yeah.
I think you got to get a measurement for that over time, because if you see a decrease in what our costs are as opposed to the helicopter service being here, you're going to be screaming wanting more of it. But we have no way to measure it right now.
Yeah, we can look at, the number of helicopter runs that in a given month, a quarter, and then measure that by EMS runs out of the county. But if that's the EMS runs out of the county is lower, then that's good for us.
And they have been.
Yeah, they have been, yeah. And then the flip side of that too, of course, the EMS get paid a little bit more when they go out of town.
Did they crank up the AC?
Yeah.
But I mean, there's more to just managing the EMS hours if you have outside factors that are helping it.
Yeah. If we got more people flying out, maybe EMS is not stuck in Tallahassee or Panama City or whatever for the whole day.
Thank you.
But that's all I have for the financials and related, position for the hospital for the month. I'd be glad to answer any questions.
Cash on hand, 77 days. 1 to 5, I'd say that's about a 5 for a hospital our size.
It's good.
4?
It's really good. Yeah.
Okay.
I'm
It's
gonna
pretty
put you on the higher end.
It's on the high end, yeah.
On the higher end,
Whatever.
absolutely. I mean, that's a healthy.
What was it? I think it was pretty close to that a year ago
Sure.
at
Yeah.
this time.
Yeah. Yeah.
Right?
Yeah.
And I think we've only dropped a couple months in
Yeah.
there. Did we go down into the 56 or 60-day period? The rest of the time, but it's on target as to last year, if I'm not mistaken.
Yeah, and actually, you'll see in the indicators, and, I'm gonna pull that up. Yeah, you look at, yeah, and I'll just make this, to John's point there, look at, again, just related inside cash, right, total cash, that's all cash that comes into the organization, but patient AR cash is part of that, right? And you look at, and again, I'm talking for the month, okay? So you look over the past 4 years for the month of October, I'm gonna use this as an example. Patient cash in 23 was 212, patient cash in 24 was just under 500,000, 25, 539,000, 26, 612,000. So to your point, cash has been going up year over year over year over year and maintaining a good steady overall performance here. So I think it has been improving, absolutely.
I'm happy with that.
And to your point on scale 1 to 5, you're in a healthier, what I would say on a higher end side of that. You're not a struggle payroll to payroll.
I remember 30 minutes one time.
Yeah.
Years ago.
That's all I got, unless there's other questions.
Anybody got any questions? Go ahead.
No, he set Heather up, though, I can tell you that right now.
Okay. Well,
Yeah,
before
sounds
we
good,
start, let's see, we have the subcommittee. Bill?
The subcommittee for finance, right?
Right.
Sorry.
All right, so we met on the 6th of November and also the 18th, went through all the accounts payable, didn't find any discrepancies, and even better, we didn't find any voided checks for you, Mr. Barry. So the good thing about that is we are looking at a separate printer. They're getting a separate printer in order to avoid any of that overruns that they may have with the common use of the printers. So that's positive. We looked at, and I think we wanted to put in place some basic travel and education passing through Alliant with Alliant employees. So we talked about how it should run procedurally, that approved education and travel expenses for Mr. Walker or whomever else that is an employee of Alliant should be run through Alliant first, processed as approved, and then a pass-through back to the hospital. And we would like that procedure to go moving forward. And I think we're gonna talk about with Jason putting something in the budget for budgeted expenses with regard to that education and travel.
Well,
Did I do that right there?
The only employee we're talking about is David.
Yeah,
We'd be the one there.
Well, no, you would be talking about Jason also, would it not? You don't go, do they budget for you to do all your travel and all
Yeah,
your?
that's,
No, there's no Weems related budget for Jason's travel.
And not for
Well,
you
what about
either.
you?
Same.
Well, how come he's
I'm not
special?
passing. I'm not passing. I'm not passing.
Well, how
I'm
come
not
he's
passing to you.
special? You all work for the same company.
Yeah.
No, no.
Ain't
That's
that
corporate.
special?
Yeah.
I don't
That's
know.
corporate. But we're talking about.
Yeah. Yeah. But we can.
Is Mr. Kozar on this phone?
But as
Yes.
Bill, as
I
Bill,
hope he's listening.
I'm listening.
Okay.
Good morning, Mr. Kozar.
Good morning.
Let me just say this again. Prior to Alliant Management coming to the hospital, the CEO of Weems Memorial Hospital, the CFO was a Weems Memorial Hospital employee per se. And so, the hospital takes care of the salary, the travel, for the CEO and the CFO. When I became an Alliant employee, as well as the CFO previously, became an Alliant employee, those pass-through costs still came to the hospital. Oh, my bad.
I may need to repeat that over again.
You're in trouble.
And so the CFO, the CEO, traditionally was Weems Memorial Hospital employees, just say before Alliant. The salaries, travel, the pass-through, those costs always came through the hospital. The agreement that the county made with Alliant said, okay, the CFO, and the CEO would be hired by Alliant, and we would still have, the county, Weems would still pay those pass-through costs. The cost for the Alliant individuals like David Bolin, now Jason is our interim person right now, but before it was like David Bolin or Tom Ramsey or Michael Kozar, those particular costs for travel is not passed through. So that's the arrangement, the county had with Alliant. Previously, before I was CEO, I was on the board. The CEO, CFO was employees of TMH, and then it was a pass-through cost to the county as well. And so that's why it's not, you're talking about I'm special, I know I'm special, but that's the system that they had here. And so that system is still the same system, and when 2018, when Michael Cooper left, when HD Kennedy came, then that's when the county said, hey, we want to hire our own CEO, CFO at that time, and they was like county, HD Kennedy was a county employee. When I came aboard, I was a county employee as well. One of the reasons why the county and hospitals have the CEO probably coming through another entity besides the hospital itself, because a lot of CEOs, it was hard for recruitment. And so TMH was involved with the recruitment of the CEO, CFO, and the same thing with Alliant, at that time. So unless the board change it and say, hey, we want all David travel to be paid through Alliant and not a pass-through cost of Weems, that's something different that wasn't done previously.
well,
And if I could add, Can you all hear me?
Yes.
Yes, sir.
If I could add, one of the reasons, Alliant, and we're not unique as far as management companies, have those two positions as Alliant employees. It's really an accountability scenario where, if we're charged to manage the day-to-day operations, and that your CEO and CFO are not accountable to Alliant, it makes our job a lot more difficult
Sure.
to be able to hold the CEO and CFO accountable for their job performance. So
Correct.
it's
Yeah.
it's common amongst management companies that
Yeah.
those two key positions are report to, are employed by Alliance, so we have that accountability to those individuals.
And I agree with you on that, but what I'm not unhearing, and I'm not reading it, is what Mr. Walker just said. I don't read that in that contract with Alliant. So I came from the angle that he's your employee, you provide for his travel, you tell us what our cost is, and we pay you that check. Now, you're, in that same logic, you set up his educational processes, you set up where he's gonna go, because he's your employee,
Right.
okay? And that, there's a link missing in the internal control process and the approval process. And that's how we got to this point.
Okay.
Yeah, that's all we're talking about.
Yeah, and what, and what, Bill just recommended is, I think, perfectly, and hopefully acceptable, that, we encourage professional development. We encourage our executive teams to continue to pursue opportunities, especially when they're asked to be, present on panels or be part of a panel discussion. It gives them an opportunity, one, to professionally grow in their career, but also, what takeaways can they bring back to their community that can be that they can learn, outside of the community.
And we do-
and what best practices can they
We
bring
want
back? So
that.
we
We want
encourage
that.
Yeah, we want
And-
that.
We want that.
And-
We gotta need a control system.
Sure.
In other words, and I have trust that nothing gonna happen, but if David goes to training or to, it needs to be approved by y'all, and then.
Absolutely.
And then we got all the procedures. That's what we're trying to
And I
do.
think
Yeah,
that's perfectly acceptable. And as you mentioned earlier too, carve out in the budget that
We're
shows
not
professional
talking about a
professional
pile of
development.
money, and I tell you what too,
Right.
it's very important, I'm seeing more and more, to gain these relationships with influential folks in the healthcare
Absolutely.
thing. That is very, very important. And I think, Mr. Kozar, you're on several committees and panels, and David, I believe you're on, what was you telling me that,
Yeah, I'm on the Florida Hospital Association Rural Health Committee, as well as the Florida Hospital Association Policy
we're right at the
Committee.
gate there, we need that.
Yeah, and so this is very important, and I think that we did, because usually, I really didn't take trips, be honest with you, the only trip I took, pretty much the Florida Hospital Association trip. But we do need to have something in the budget, because I just got an email I sent to David, from Becker's inviting me to be on the annual meeting conference, as well as the one in December. So these people, they've always invited me, I just never went, per se, as a panelist. And from the last trip I went to, they was asking me about Apalachicola. I had to pull up a map and show them what we were
really?
doing, what we were doing.
Forgotten Coast.
But the thing of it was that we had a good chance there to showcase our little small town, really, our hospital, the partnerships that we're making. But I do think, you're right, we need a system in place, and I do need to have something.
We're not debating the need for your
We just got-
education
we
in
got a
places.
county.
We're just talking about the processes
Process.
of how we're gonna set the billing on it, that's all.
Sure.
Yeah, we all agree that you need to be there, and probably even more so with everything that's coming out with the one big
We
beautiful
want
bill.
our piece of the pie.
Yeah, and
Yes.
all that
Yeah,
money
we
that's
want-
coming out.
We need to have somebody there to
We have
get
to
our
be there.
piece of the pie.
Yeah, we have to be there, so, no, we appreciate that and all the work that you're doing on that,
And
so.
if you're already there,
absolutely.
you can't uproot them, you know, you know how that works.
Yeah,
The only-
and we're acceptable to the process.
Okay,
Yeah,
let's-
and the only other piece that I had, and I don't know if you're gonna go into it, Mr. Walker, but, the Alliant management contract that we discussed. Are you gonna
Yeah,
talk
that's
about
on-
that?
Yeah, that's on the agenda for the board to discuss.
That's for me. That's for
Okay, all right,
Yeah.
I'll leave it at that.
Okay, Mr. Kozar, wait a minute.
No, me.
Let me, subcommittee, okay, let me skip right, I see Kevin came in. Is Kevin
What are
gonna
you
be on?
doing here, Kevin?
Yeah, yeah. Well, I got on my report. Come on up, Kevin.
Well, he's sitting there doing
Yeah.
nothing.
Why are you here, Kevin?
No, I got on Melanie, pass out my stuff, Mark.
He's under the, Mr. Walker's.
Yeah, it's under my report.
I just, Kevin, I don't even waste his time right there. Let's get to that first,
Yeah,
okay?
yeah, we'll get to Kevin.
I think I'm here just for policy stuff.
That's all. And what I wanted, Melanie is passing stuff out. The blue sheet that you have, that she's passing out there, have IT policies. At the last board meeting, you know, we sent the email out to you to look at all those policies. I don't know if you looked at them or not, but we really need an approval on those policies, and then Kevin and I can work, and we can begin to flush them out, per se, because we didn't do it at the last meeting. And so we wanted me to come back at this meeting, you know, after you all had a time to look at them, but it was like 30.
Have you?
Can I beg forgiveness? I haven't had a chance to.
I haven't looked at it either, but.
Okay, let's
Delay it.
delay it. We haven't looked at it. We gotta look at it.
Okay, delay it, but make sure because I'm trying to get it done for the audit end.
We gotta
you
get
know,
this
so
done
it's-
for the
it's a
audit,
little-
y'all, so.
Do we have enough time to do
Yeah,
it
we can, I
for
mean, we
next
can come
meeting?
back, I can tell Brian, you know, we can do it in January, but make sure you look at it, and then if you have any suggestions, let us know, because we're gonna work through them. You know, we
Okay,
wanna make sure we
let's
work through
Make
them.
sure, board members,
Yeah.
let's read up on that, and we gotta move on it.
And then we
Okay?
wanna tell the auditor that, you know, hey, you know, these are our policies that
Well,
we
let me tell you
implement.
what, if it's, I like to look good on the audit, and I don't want the board here to, we worked hard on this. If we had to have a quick special meeting, we could do that sometime.
Yeah, and these policies like you know, we just went over beyond the audit, what audit asked for. You know, we just went over beyond, really.
Are these policies, let me ask this question. Do they stand alone, each policy, or are they interwoven with each other?
I mean, any policies, I mean, they're all gonna be kind of interwoven in some places, but they are
you're gonna have
standalone.
the access control will be policy number one. Accounting disclosures won't be included in access control. It'll be a separate heading up there. So these are all
Yeah,
separate.
they're
Yeah,
separate,
they're all separate policies, but
Okay,
they
good,
might
good, that's
but they
all.
may relate to.
relate.
Well, they'll relate to each other, sure, okay. Is that what,
Now, did you
that's what
send,
I want to know too.
David, did you send an email on this?
Yeah,
And what was the date on that email?
at the last board meeting.
Send another one.
Right after the last board meeting?
Yeah,
Okay.
it was,
Did it come from
You-
Heather or
we-
you, Kevin?
Heather, October 25th, I think. right?
Can we just send it back to them? There we go.
Yeah, we'll send it back to you. We'll
I just wanted to make sure we could access it
Yeah,
and
yeah,
find it.
we'll resend another email to you. You know, that way you can look at them, review them, and still, if you have any questions about them, you know, let us know. But and then Kevin and I, we still can work through them.
Little out of my wheelhouse, but I trust you with my life, Kevin, so.
Nice, thank you.
I tell y'all what, when you do this, and let's expedite this, y'all, why don't you send David a quick email, reviewed, approved, or reviewed, and have questions, or whatever you might want, okay?
Yeah, comments that you may have, and then I
Let's
will
get
Kevin.
moving on this now.
And then at
Yeah.
the next board meeting, you know, we
Okay,
we'll,
all right.
yeah, discuss it.
Can I go back to the question I asked originally?
Yeah.
Are they interwoven? Are they standalone separately? Are they in different categories with regards?
I mean, they're standalone, but each one might have something to do with another one later on, but they're all, it'll be mentioned in the policy if it does.
Where the hook is?
Yeah.
Okay,
Okay, that's good.
good.
Okay.
I apologize for not getting on them already.
Yeah, these a lot, I mean, like I say, it's a lot of policies, and this is something that we've, we just going over and beyond on this.
This is quiet time work. You don't need anybody disturbing you whenever you're going through.
Okay, all right, thanks, Kevin.
All right,
Thanks,
thanks.
Kevin.
You got a what?
Okay, Melanie gave you all some information. This is the board report. I'm going to talk about the Florida Rural Health Transformation Program application. Heather sent something out on the email. I sent out this document here, as well as this document as well. And here's the application, the Florida Rural Health Transformation Program application that was submitted by the Agency for Healthcare Administration.
Beautiful.
This application is part of the One Big Beautiful Bill. And so part of that is that the states have been asked to submit an application for CMS 5 national goals. And so before I even get into detail with it, I just want to bring your attention to also, many of you have heard last year during the state legislative session, the Senate President, Bill Albritton, had a bill called the Florida Rural Renaissance Bill. That bill did not pass last year, but he probably would bring that bill up again for the legislative session, and it may have some health-related stuff in that bill as well. So that's just coming, in case you hear Florida Rural Renaissance Bill,
Yeah.
you know that is different from the Florida Rural Transformation Program. Florida Rural Transformation Program application is a federal application.
It's a federal app, yeah.
The federal application. So we have this document here. I'm gonna go through this quickly for you here. So the Florida Rural Health Transformation Grant Program, ACA submitted the Florida's application to CMS by the November 5th deadline. All 50 states submitted an application. States directed to submit applications based on $200 million annual for 5 years to award. ACA also may retain up to 10% annually for administration. These particular monies.
Did y'all, just one second, y'all catch that?
Yep.
10%.
10%.
10%.
Off the top of a what was it?
200 million.
Billion, and then we get a certain portion of
Yeah.
the state?
Yeah.
Right off the top, that agency wants 10% of it.
Yeah. So $20 million. So
There you go.
yeah, 20 million right off the top.
Who? I missed it.
But that's
I missed something. Say that again. Dave.
okay. All right. So it's a $200 million grant, and the $200 million grant indicates also that ACA may retain up to 10% annually for administrative functions. And so that's going to be split between the state operations and the regional administrative offices. So what ACA is the Agency for Healthcare Administration. All right?
I know.
They will be the minister of the grant. And so they say they need 10% of the grant amount, which will probably come up to $20 million, to administer this grant out to the different collaboratives, which I'm going to go down and talk about that in a minute. And so the admin fee. Back in the day, the
They don't
admin.
have staff right now, right? They
What?
don't have staff to administer, so they gotta spend $20 million to go get people.
Yeah.
Go get hired over there.
That's their interest. That's pretty much just their interest.
And that's on an annual basis.
It's on an annual basis, yeah, yeah.
That's crazy.
Years ago, we, and John may know this, because accounting, usually on federal grants, usually, I think the admin fee had to be, what, 5%, 7%, I think?
3%.
3%.
This is 10.
And so this is 10, so, so they're gonna get a piece of the pie.
Before we get ours.
So that's only the top piece of the pie.
Yeah,
Keep
that's-
going, I'm
Yeah,
sorry.
all right. So, so the state of Florida, with their particular grant, their program design fund rate, they're funding 15 identified initiatives that will be distributed by rural populations shared across 4 defined super regions. And so ACA is defining the super regions, almost like they have the state Medicaid managed care regions. So you have like a region 1, will be in like the Northwest Florida area. You have region 2, probably will be in Northeast Florida. Then region 3, Southwest Florida. Region 4, Southeast Florida. So these are the what ARC is calling the super regions here. Now, the Northwest Florida region, which would encompass us, they want to, ARC will make an award amount of $41 million.
Listen to this closely.
Okay, $41 million will go to the Northwest Florida region, which is our region here from Pensacola, probably all the way to Tallahassee area. The Northeast Florida region would be $81 million. The Southwest Florida region would be $47 million. The Southeast Florida region would be $14 million. And they say that they did this based on the rural populations in those areas.
So the rural population, if they did it that way, the rural population all sits over in Northeast Florida, right?
Yeah, well, that's what, the rural population, Northeast Florida they're getting $81 million. So
Versus,
the Northwest population, which is coming from our area all the way over.
41 million.
Yeah, 41 million versus 41 million.
Twice as much.
Yeah. Now, let me just give you a breakdown of the regions, and then we'll get into application. So Region 1, so they don't have super regions. Region 1 and 2. Region 1, of course, Escambia, Okaloosa, Santa Rosa, and Walton. I believe that's going to be Region 1A out of the Northwest Florida region. Then you got Region 2 in the Northwest Florida region, which would be Bay County, Calhoun, Franklin, Gaston, Gulf, Holmes, Jackson, Jefferson, Leon, Liberty, Madison, Taylor, Wakulla, and Washington. Okay.
What's their allocation?
Yeah, and so that's that. Excuse me?
What's their allocation of the 41 million?
Well, we have to decide that, because that 41 is probably either going to be, should be split, I think, should be a 50-50 split out of 41, but it all depends. And then you got Region 3, that's that Northeast region, Letchworth, Bradford, Citrus, Columbia, Dixie, Gilchrist, Hamilton, Hernando, Lafayette, Lake, Levy, Marion, Putnam, Sumter, Swanee, and Volusia. So if you have any rural counties in that area, they will get that particular money. And so ARC has broke these down in regions, but what they're doing is that they're looking to award monies towards the 15 initiatives to be distributed by rural population shared across defined super regions. ARC may issue statewide awards when shared infrastructure or efficiency gains benefit all regions. Now, regional collaboration model. ARC will be looking for a regional collaboration model, meaning that it's going to be very important that individuals participate in a regional collaborative that is formed in the super region, meaning that all these hospitals, your federally qualified health centers, like North Florida Medical Center.
Let's break that one down just a second, because this is very, very important. When you say regions, go back to the district, the 5 counties over to the west of us.
So you got Region 1, which you have you have a Northwest region, you have a Region 1, right? Then you have within that Region 1, you want to have a Region 2.
Now that's where the collaborative effort has to come from.
But it has to come also within the region too, within the collaborative, within the counties. So all of these counties are going to have to work together.
And then who's at the table for those counties?
Who heads it?
Okay, so.
David, you got to place that table.
Yeah, we all going to be, so how it is now, as I go through, and Michael Kozar can talk about this as well, because he's been at the meetings. All right, so right now, we've been meeting, we have about 6 hospitals, CEOs, that has been meeting, that's in Region 1A or 1B. You have Calhoun Liberty CEO, you have Jackson Health, Jackson County CEO, of course you got Michael Kozar, Northwest Florida, you got Taylor, Doctors Memorial CEO, and myself. So the 5, Madison County CEO as well. So you have about at least 6 CEOs that's in this region here. We're coming together to meet because we're saying, hey, we want to be at that table as well.
But you're talking about this the sub-region, as opposed to the big region that covers Northwest Florida.
Yeah, but we still going to be a part of
that's 2 parts.
Yeah, we still going to be a part of that big region that's covering Northwest Florida. Because right now, the collaborative, there's a lot of different hospitals starting to meet on this, per se. You know, we took it upon ourselves to say, hey, let's form a collaborative. Let's begin to start meeting right now.
You're gonna have to do that anyway.
Yeah, we're gonna do it anyway. Then we'll be at the table. You know,
Well-
although ACA now, for the administrative money, here's what I think ACA may do.
Before you go there, can we finish breaking it down?
Yeah.
So they all understand completely where this, how it's gotta be divvied up.
Yeah, all right, so you have, once again, you have, you know, the Northwest Florida region, which will have a 1A and 1B.
And we're in 1B.
We're in 1B.
Four super regions.
Yeah, you got 4 super regions across the state. You know, you got a Region 2, you know, that's Northeast. They're gonna have a Region 3 and 4, A and B. Then you have a Region 3 gonna have the Southwest region. They're gonna have Regions 5, 6, and 7, and 8. So they probably have about 4 of those, like an A, B, C, D, in their super region down in Region 3. And then Region 4, 9, 10, 11, that's the southeast part of the state of Florida. But it has to cover rural counties. You know, so you really got to cover, you got to remember, it has to cover rural counties there for that. And then out of that, each collaborative in that region must submit a single cohesive proposal designed to meet the needs of the rural area for which the regional collaborative represents.
So the 5 CEOs in district, in 1A,
Yeah.
or 1B, 1B, have got to come up with a plan. Then there has to be agreement between that and 1A as to
The larger
an
bucket.
overall portion of the plan. Okay.
Yeah.
Well,
Well,
if
go
I,
ahead.
if I could add something there, David, you know, when you look at our region, or our super region, if you want to say, and the 2 regions that are in the Northwest area, the majority of the rural hospitals for that are in our region. You know, because if you look at the western part, there may be one, maybe 2 hospitals that would be classified as rural in that 1A. Most of the rural hospitals in our region are going to be in 1B. And as David highlighted, you know, we're in the process of formalizing and officially putting together a network so that when we come together as these CEOs, because, you know, we initially started this with the 5 or 6 hospitals that we have, there's other ones that we'll want to invite in, mainly Holmes County, Walton County over there at Defuniak Springs. You know, to be able to put together, and the overall goal is for us to be able to develop a network that we will be able to draw down some of these funds as a network, and then be able to look at how overall we can, again, protect our portion of the money coming down.
Okay, so
What we want to avoid is, you know, and what we're seeing out there right now, there's a lot of these companies and organizations that are trying to get their hands on this money through one way or another. So by the hospitals coming together and saying, okay, we want to do this in the best interest of our region, I think we'll have a valid mechanism in place to be able to solicit and draw down those funds.
can you address what the players are with regards to the big hospitals, and I'll use TMH, and how they participate in that, and go down to the lowest level of where our CEOs are on the same level as all these private little health clinics and so forth around, and how they share in that money.
Well, you know, and again, I think things still need to work out, but what we would be looking at is our network that we're putting together. We would then look at, you know, organizations that can be best suited to fit our overall goal of what we're putting together to drive down specific topics and issues. You know, we know that, for example, pan care, you know, is a big player in our region. We will need to sit down and talk with them because there may be some collaborative things our hospitals and pan care can be doing together to draw some of those funds. Again, the overall goal will be to look at how we best be able to maximize our reimbursement through qualified programs and services that we're going to offer to these rural communities to improve. The ultimate goal is to improve the overall health status of our areas. So we'll be looking at those projects and those various activities that qualify for these funds and how we can best utilize it. So, for example, you know, IT infrastructure or tech innovation. You know, we may be looking at, you know, a collaborative amongst the hospitals. And one of the topics we talked about is, do we have a host site that we can look at IT aspects, and that host site may be a TMH. It may be, you know, another organization that we can tap into some of their IT resources, but to expand that into our rural communities, whether it's, you know, for example, you know, home monitoring. Home monitoring is I truly believe is a big thing that can help the overall status of patients' well-being, but getting the infrastructure that we need to do, that's another area that we'll be able to hopefully draw down funds to be able to build out that avenue. But again, to your point, John, what our goal is also to try to limit what the big facilities, the big hospitals, to ensure that they're not gobbling up the money and we're not seeing it.
So, Mr. Kozer, are we already collecting the kind of data that CMS wants to see? And from what I'm understanding is to participate, you have to be in that super region, correct, to keep it locally focused?
Right, correct. And you know, we have another meeting set up on December 6th with the committee of these hospitals to look at, and we've brought in, you know, the Department of Health to make presentations. We're also looking at grant writers that will enable us to help in applying for these funds, so that we are ensuring that, you know, we're putting together what we need to do to drive those funds to our
When
organization.
do the application process start? Like, how?
Well, it looks like the applications are due March 20th.
March 20th, yeah,
This has to happen quickly.
Yeah, so we gotta get the ball rolling.
it's a fast time. This is one of the things, you know, I don't think I ever seen, you know, money's this magnitude come down to move so fast. Usually you have a planning period, you have you know, to do this, but
Who writes the check?
Jim-
ACA? Who's gonna write the check to us?
well, the federal government gonna get them under the ACA, Agents for Healthcare Administration, and then Agents for Healthcare Administration send it to the super regions here. But the grant application, the RFA will be advertised and released on
How are we gonna figure out by March 20th what we want here? I mean, I'm looking at this. I mean, I'm just,
You're on target.
I'm kind of,
Who's the grant writer? Who employs the grant writer? Do y'all employ him?
Is that something Alliant takes care of?
Alliant?
No.
No.
No,
So who
that
has
will
to
be
do that?
something that the network will decide on who, you know, how we're gonna compensate this grant writer, and it may be,
So a
you know.
collaborative.
Yeah,
Okay.
the collaborative would. Yeah,
I gotcha.
Yeah, the collaborative will decide, you know, hey, you know, who will be the grant writer for this collaborative here?
well, I'm just gonna tell y'all, I'm a little confused. I'm reading something here. Will provide funding support to enable rural providers to transition from fee-for-service model to performance-based payment models offered through managed care plans that require quality, efficiency, and care coordination rather than volume. I don't really know what that said. And then the next sentence worse. I mean, how they gonna figure out what quality? How do you? I mean, I don't.
Well,
I don't
the thing-
understand. some of
Well,
this.
Duffy, on that, you know, a number of years ago,
I'm just saying.
there
I just
was
picked that up.
there was a push for rural, what they called ACOs, Accountable Care Organizations. And there was a pilot project done that was to help rural hospitals, mainly critical access hospitals, to help them to try to transition to this value-based care initiative. There was federal funding, and a lot of our organizations, and I don't recall if Weems was a part of one, but a lot of your rural hospitals came together to form these ACOs to help look at how do you drive down, or I shouldn't say how do you drive down, but how do you move to more value-based care? Well, when that funding ran out, it was cost prohibitive for any of these organizations to keep that initiative going because you weren't getting enough reimbursement to cover the cost of what you would be doing. Okay. So, this is another, in my opinion, another step towards that movement, to try to drive organizations instead of, again, to their point, instead of us focusing on how many patients we have heads in beds to how many people are we providing overall health care services to that's going to limit the expenditures that CMS has to make on Medicare patients. Okay, and that's by keeping them out of the hospital. Okay, so it is a movement from what we have traditionally seen as how we determine success is, and we talked about it earlier in this meeting about getting more swing beds, getting more admissions into the hospital, getting more utilization, and moving more towards how do you get reimbursed at a higher rate or a per member per month type of mechanism that you keep those patients out of the hospital, or you find ways to find the most financially I'm struggling with the word, but how can you more efficiently care for a patient without the high cost of inpatient admissions?
Okay, well, Michael, I understand a little better now, but did any of the board understand until Michael gave that good explanation? Had y'all did understand it?
I
understand
been
it.
Studying this thing for
I
a
have
couple
to
of weeks.
understand
Okay, well, what I'm asking is,
let me just.
what I'm going to ask
Okay.
is, it looks like there's good plans underway to take care of this. Are we going to have to determine what we need at this hospital? That's one thing we're going to have to determine.
Well, we got to determine what we need, what we want to do for our community.
Exactly, that's what I'm talking about when I say
And so,
need.
for example, Weems, we're not going to try to hit all 15 of these initiatives. For us, what I mean, it may be, of course, you're looking at the specialty care.
Or telehealth.
Before you go further.
Or telehealth, correct?
Telehealth, yeah.
Before you go further, Mr. Kosar.
Uh-huh.
Does Pan Care have an equal seat at the table as Weems Hospital?
I don't know yet, John. I just have, we've got to work through this a little bit more. I know they're going to want an equal seat on that. I just don't know how that's going to play out yet. It's too early for me to be able to say, yeah, are they going to have an equal seat or not? I can't really comment on that yet.
Yeah, because
Well,
what's going to happen is that you got PanCare just serve a certain part, but you got North Florida Medical Center. You also have Bond, so you have a lot of federal qualified health centers probably going to want to. I'm sure they probably meeting right now also, like we're doing, for this particular certain parts of this money here.
Well, I got a question here. I'm trying to clear it up. I read this the other day, and under Initiative 1, rural and satellite clinics, 25 annually for 5 years, 25 mil. Initiative aimed at encouraging urban physicians to expand services in rural areas by opening newer satellite offices. Okay, good. funding all supports physician assistant and nurse practitioner-led clinics, will offer primary care, dental, chronic disease, obstetrics, general, mental health services. When it says will, that means that clinic would have to offer all those
Doesn't
things.
say shall.
Huh?
Doesn't say shall, it says will.
Will,
Yeah,
yeah.
will.
When it says
Yeah.
will, yeah.
But that's not as strong as shall.
Yeah, yeah, and so what,
Okay,
yeah,
okay,
yeah,
okay, that's right.
okay,
you're right.
okay, so with this.
See, I mean, I'm just curious.
Yeah,
I mean,
okay, so with this satellite clinic, and that's something that, I'm sure will be in some questions and answers to ACA as well, because it says that the initiative's aimed at encouraging urban physicians.
Oh, no,
So-
that's
So,
good.
so what it's saying is that they want to encourage physicians in Panama City or Tallahassee to come and open a clinic here in the county. Or if a nurse practitioner, want to open one on her own, which is pretty good, they will help that out. But my question to them would be, can a hospital open their own satellite clinic, like in a Lennox Village, or wherever we think the need is in our county?
What about your mobile bus that you and I talked about?
Yeah, yeah.
Will this fall under that?
Well, that's what we got to get clarification.
Yeah.
So now
Yeah,
you write a grant till you know what,
yeah.
ask for a grant till you know what you're.
Well,
What you need
isn't,
here.
isn't some of the problem here with if you've got a urban hospital, they decide to put a clinic up in our rural area, they're gonna suck off some of that funds.
You darn right.
Yeah, but that's,
I'm not here.
well,
You got it.
well, that's why it's in the document. That's what I'm saying.
That's the problem. I
That
mean,
document
your
there-
this is for rural hospitals, and the urban hospitals are gonna take a piece of that by opening up a clinic in our area, in our
You got
rural
it.
area,
The
correct?
lights on.
Yeah.
No,
And here's the deal, though, but it's written in the policy here. And so the question and answer would be to the Agency for Healthcare Administration when they open up question and answers, can rural providers open up their own clinic? Would they let us do that? Because here, it doesn't say that we can, unless we have even with if you have a nurse practitioner, or like somebody, for example, say Kristen coming out, she wants to open up an office, now this would allow her to do that, per se. But for as a hospital or an existing facility, it doesn't say anything about it. We have to get some clarification.
Can we have pre-existing clinics?
Yeah,
See, in other words, if we go for the funds, do our pre-existing clinics qualify to be part of that?
it probably won't qualify to be part of that, but you.
separate from the hospital.
Yeah, either
Well-
separate or part of it.
Well, but the,
It's
but
where
the
you
thing,
get the most bang for your
Yeah.
buck.
I think the thing that could help us too is if you look at, provide training and assistance in the provision of healthcare service items and being able to recruit physicians and providers to your community, that may be an avenue that we're able to benefit our existing clinics by bringing in these providers that, if we can get financial assistance to, and I'm using an example. You have a student that's in medical school at FSU. He's from Apalachicola, wants to come back. Can this program provide financial assistance to the hospital to be able to provide financial assistance to that potential doctor to come back to our community and practice in our areas? So I think that's an area that we may be able to help our existing clinics in being able to get some of our monies that way.
Yeah, 'cause
How about this, how about this solution?
that's initiative 8 there.
How about this angle? Can we build us a organization or start to build it like Dr. Hart had, and it would qualify for these funds?
Like a doc
A
group?
physician group.
Yes.
A physician group?
Yeah, you know where I'm going.
Group, yeah.
And John, that's a good point, and I think we need to look at that. I mean, can we form an organization that engages these physicians that would also qualify
Or
for these
mid-levels.
funds? These are all things I think that
For
we
all
got to
five,
explore.
all five of the sub-organizations.
Right,
Yeah.
exactly.
Yeah, and so let me just go down quickly, Duffy, for the sake of time. I'm just gonna go down. I'm just gonna list the names, the different categories, so people can have an understanding of that. All right, so the first one we talked about, the rural satellite clinics. That's with the urban physicians or the nurse practitioners only, or mid-levels. Then you have what they call mobile health, almost like a mobile health unit, to integrate, to go around doing screenings, prenatal services in rural communities, a mobile bus. That's 20 million annually for 5 years. The community paramedicine part, we know that we'll probably do that one because we've already doing that. That's 18 million annually for 5 years. So that's for people that in different other counties that do not have a community paramedicine program, but we have one, so that we should be able to connect ours with that as well. Initiative 4, behavioral health, telehealth psychiatry hub, $18 million annually. So it's saying that each region will establish 5 regional centers that will have a psychiatry hub that the rural providers can connect with. And then Initiative 5, telespecialists, imaging, virtually specialty clinics, $16 million annually. That's another specialty hub, for different specialty groups like cardiologists, oncologists, which we'll talk about in a minute, and neurologists via telehealth. So that's something else we'll look at. Then you have Initiative 6, tele-intensive care unit, that's $14 million a year. And so we'll enable 15 rural hospitals to connect with remote critical care physicians. You have Initiative 7, hub and spoke telestroke, $10 million annually. Then we have Initiative 8, that's the workforce development, $10 million annually. That's what Mr. Kozar was speaking about for the training. Then you have the health and lifestyle Initiative 9, $7 million annually. This mostly has to do with students, so you probably have somebody like the school district probably get involved in this initiative here. You have Initiative 10, remote patient telemonitoring. Mr. Kozar had talked about that before. And then Initiative 11, we talked about value purchasing. That's $10 million annually for 5 years. The retail clinic services, Initiative 12. Initially, I thought when I heard retail clinic, I'm like, maybe we can use this money to open up
Pharmacy.
a pharmacy.
Yeah.
But really, what it's saying is that it will reimburse our local pharmacies if they hire a nurse practitioner to do some sick visits. in
By
that area.
right. Those
Yeah,
people like
yeah,
that.
by right.
See, there you go.
CVS.
More than five.
CVS.
CVS, like how CVS does in the cities, they have a nurse there that does sick visits. Initiative 13, this is what they call the Florida Information Exchange, Florida HE, encounter notification system, which ACA kind of run. That's a system that we're a part of that right now that allow different health facilities to talk to each other. When you make referrals, that's just electronic messaging.
So ARC is going to take their 20 million plus another 5?
Well, yeah, are the group that they contract with right now.
Yeah.
Because I'm gonna tell you what's gonna happen. The group that they're contracting with right now. Well, I can't say that anyway. But the group that they contract with right now does they do the Florida Health Information Exchange already.
Right.
So they're gonna add another $5 million annually.
To their,
This
to their
money
20.
that you keep throwing out there, that's part of what lump sum?
Okay, that's part of the lump sum that goes into the collaborative.
The 200 million?
Yeah, that's part
Is
of
that
it.
part of the 200
Yeah,
million?
yeah.
So you can see how it's broken down.
Minus 40 or 20 or something like that.
Minus-
Yeah.
I said for that minus there.
Now look at, we don't know how they came up with the formula for how they broke the money down. Now Initiative 14, which is the diagnostic technology support, $6 million annually. That's for the equip rural hospitals to develop PICE systems. We already have a PICE system with our radiology group, so I don't know how that's gonna really help
Benefit us.
rural hospitals too much unless you need money to pay. Initiative 15, which is $1 million annually. This is what we were talking about earlier, John, integrated Medicare, Medicaid plans, education and outreach. So there's some money there, that you can use to hire
You gotta get it.
a navigator. And you already have some groups in the Big Bend that did this, that got grants before, like Big Bend AHEC. They had grants like this before that they came in to educate the community on the different Medicaid and Medicare plans for that. ACA will establish a governance committee with members from ACA's Agency Leadership and Rural Health Program Office, and then with 14 staff to support the coordinated implementation, data-driven performance oversight. So that $20 million that they're gonna need, they're gonna hire these people to kind of oversee what's going on. RFA advertised and released January 28, 2026. Submission of application questions February 14, 2026, anticipated posting agency responses to questions. February 27, 2026, applications due, 3/20/2026, anticipated posting of grant awards, April 21st, 2026. So that's kind of like in a nutshell of this particular monies here. Now, this is going to be good for for community projects, but the big beautiful bill, one big beautiful bill, this does not address the lost revenue, but hospitals going to face when individuals get kicked off the system. And so I'm just putting that out there.
When they get kicked off, what's
Medicare,
Medicaid.
the Medicaid
when does
system.
that happen?
Well, it's probably in the January. I guess they'll extend it.
It's gonna start happening.
Yeah, and some premiums already have went up. You know, I know Florida had, you know, we have a high percentage of people on the ACA Affordable Care Act. You know, I think maybe 2.4 million people, I believe. But I know in Franklin County, we may have about maybe 1,900, 1,600 that may feel the impact of the premiums going up. Maybe 600 people, I believe. So you're gonna have a lot of people get kicked off.
That's about 20% of the population.
Yeah, could be, yeah. So you're gonna have a lot of people get kicked off, but we still gotta see. But this grant does not cover that. I'm just telling you in advance. So when that, you know, as even when we begin to do these programs in the community, you know, I mean, we got to keep them afloat, but people still got to pay for services. It's not that they can't come for free, but it may be a lot of uninsured that we may be dealing with in the whole scheme of things next year. You know,
What you're saying is basically these are restricted funds for these particular initiatives.
Yeah.
Therefore, they are not general use funds
For
that
lost
we can
revenue.
use for
no,
No.
operations.
operation, no.
Right.
Yeah,
But
it's gonna
these
be-
initiatives that they have down here, were they part of the Florida's application to
Yeah.
One Big
Yeah.
Beautiful
Yeah.
Bill? Because they had to
Yeah.
put in what our initiatives would
Yeah.
be out of a whole list of initiatives that the
Yeah.
bill required.
All
right?
50 states.
Yeah.
Yeah, but this is
Yeah.
what Florida,
Yeah.
these initiatives are what Florida overall
Yeah,
said that
submitted.
they want
Yeah, yeah.
in their application
Yeah.
to the Fed.
Yeah. Now, one thing also we hadn't seen too, the Florida State Legislature, you know, they hadn't had a lot of input into these initiatives because ACA had to submit this before the legislative session had started. Reason why I'm saying this because some legislatures may come back and say, hey, you know, I think this need to be the priority. You know, I think we need to cut that out. But the application has already been submitted to the federal government. The federal government gonna make their awards, you know, based on what they want to do up there.
What
Not-
was
not
y'all's
local.
participation? What was Alliance participation in the development of these?
John, we were all asked, you know, and it wasn't really as an align, it was more of a hospital-based thing. We were all asked to submit our priorities and our thoughts on programs and things that, you know, this money could be used for. That was what was asked of each hospital in the state of Florida to submit both rural hospitals, there was two categories, rural hospitals and urban hospitals, to submit their thoughts and ideas on how to develop this plan. So that was basically our involvement.
Did you
Did
submit
you-
one for Weems?
Yeah, I submitted one for Weems.
Okay.
Yeah.
Have we seen that?
You know, it was a survey. Is that they ask you questions?
Oh, it's a survey.
Yeah, they ask you questions on the survey. Now, however, we've been meeting with, like, Florida Hospital Association with me, you know, and, you know, talk about, you know, what's coming out. You know, Florida Hospital Association had a meeting with the Federal Qualified Health Centers, people that lead that particular organization. So there's a lot of questions and submissions to ACA, you know, because there was a big plan that came out, but all that big plan was not in the application that was submitted.
Does Alliant have grant writers?
No, we don't have a specific grant writer. Each hospital has typically, you know, engaged their own. But, you know, we have developed a great relationship with, and David, I'm drawing a blank on him, that done a lot of work.
Dennis,
at Calvin Liberty.
Julie Dennis.
Julie Dennis, yes. And she's actually going to be at our December 6th meeting, or December 4th, I'm sorry, 4th or 6th, I'm trying to, I think it's the 4th. that meeting to make a presentation to the group of hospitals about what they can do. The other thing I just wanted to mention is you went down through that list, and the question was earlier, how does the big hospitals play into it? A perfect example is the telestroke program. You know, if our network of hospitals say, okay, we want to go to TMH or Capital Regional or Bay Medical, and we want to develop a telestroke program for our facilities to be able to, when that patient comes into our emergency room, have a connection to neurologists to be able to determine the treatment for that patient. That would be an example that we would pull in, because none of our hospitals have the capabilities of having a neurologist on our staff, so we would look to a tertiary facility to be able to provide that service for our network of hospitals.
Have we seen the submission that Alliant prepared for, I guess, the rural hospitals in this area
You're talking about what submission?
to ACA? Did we?
No.
What was our input to ACA?
No.
Yeah, amongst the leaders circulated amongst themselves, what they, each of their responses to the survey. That's what you're asking.
Right, I mean, is there some documentation to that?
The survey.
Okay. Yeah, I don't think, because I couldn't get my survey back. I don't, I can check, but usually, one of the things I put on there, the lost revenue. I mean, I didn't think they said, they was talking about the big beautiful bill, what other things that, that is needed. I'm like, well, lost revenue. I think this should have covered that. I know for us, specialty care, that was one of the things that, that is lacking in our particular community, as well as primary care physicians. And some of the things in here that they included, in the agreement, have some of the things that we've, like, say, we would need, that kind of help with. But for us, now there's another document that the Florida Hospital Association did in conjunction with the FQACs. That's a bigger document. But for us, the survey, I didn't get my survey back that I submitted.
All I want to know is there any documentation we can look at as to what was submitted for this area?
Your survey?
Well, yeah.
You want to see the
You want to see
survey?
the survey?
Survey, and if we're having to be
Yeah.
married to 4 other organizations or 4 other areas, did all
Is that my
5
survey?
cover us also, or is
Yeah.
just our one
Yeah.
submission cover us?
Well, no, what happened was our Agents for Healthcare Administration sent out, not agency, but Florida Hospital Association sent out a survey, to the CEOs, hey, this is a survey for the priorities that you may need, that you will want to see. I did a survey, now that survey, I did not keep that survey because there was no place for me to download the survey that I had. And so,
So we don't have any documentation on the survey or whatever we submitted. Alliance submit anything that's documented?
Not as an organization, John. We did it as individual hospitals.
It had to be individual hospitals.
Because technically Alliant is not as an organization, is not a member of FHA.
'Cause you'd have
And
to submit it to all your
FHA was
hospitals.
putting that out, so we wouldn't have been eligible to respond to that survey. But our individual hospitals, our 4 Alliant hospitals, all submitted their responses and thoughts on that survey to be submitted.
because FHA doesn't ask Alliant to submit a survey.
Okay.
It asks the hospitals.
we're-
Anyway, we down the line.
We can stay on this all day, I believe.
Yeah, you could.
I mean, I don't know where you quit, but I got 2 questions. Is there, in the immediate future, is there gonna be some board approval needed for some of this stuff, correct?
It could be when we, even if, when we looked at the collaboration, see how the collaboration is gonna roll out, because right now, and Kozar talk about this too, we all meeting right now, trying to figure out how this is gonna look,
Understand.
per se.
Well,
Who's the grant writer?
if there's timelines to be met, the board, we might be having special meetings, what I'm trying to say. Okay? Now, is anything in here gonna need if we think it needs the county commission approval, I might have to ask them to do a special meeting. So I think we're proceeding the best we can. I think we could stay on this all day long. I'm gonna try to read this more thoroughly, but I read it, but there's some things that kind of muddle me up there a little bit. And I do think that, David, you need to present this to county commission. Have you talked to them about it?
Yeah, what I'll do, in my December 3rd meeting, I'll be at the county commission for the radiology agreement approval, and I have this as an information item, for the county commission.
Brief them on what's going on.
Yeah, brief them what's going on.
Because it's not complicated. It's a complicated issue. So,
because it's not only hospitals got to come together. The county. You got the county health departments. You got entities. You got the county also. So, the county may want to, of course, since I'm in health, the county may want to have a designee from the county to be part of the collaborative. I'm just saying.
Okay. One thing we all need to remember, we want our piece of the pie. However,
EMS will need to be a part of it.
We want good medical treatment for the county, so that it might be a trade-off there somewhere. I guess.
All right. I know there was a whole long period on that one there.
So what's next step?
Well, the next steps would be
Application.
The application. The collaborative would meet. I brief the county commission on December 3rd, but as I get more information out, I'll make sure I pass it on to the board as well.
You're gonna have to.
March is the deadline?
Yeah, March is the deadline. And that's for the whole state of Florida.
Okay.
Now those deadlines can change. Now, there's nothing etched in stone with state. We work in state government, and we know that those times did not measure by those times.
Go ahead.
All right. I want to have item D, potential service line opportunity. I want to have Kristen to talk about the oncology services that she spoke to me about.
I'm gonna pass out these
Yeah.
pamphlets for everyone to see. You just wanna take one and pass them down, Ms. Martis? Actually, I have one too. Okay, so I was contacted by Main Street Incorporated, and they have a proposal out there for a partnership to establish a hospital-branded cancer center on site at Weems. So this model has already been successfully implemented in over 900 clinics across 18 states, with expansion underway in 26 states. Their approach is designed specifically for rural communities like ours, bringing world-class oncology care directly to patients without requiring any upfront investment for us or financial risk for the hospital. So this is how it basically works. And I've been working on this for a few weeks. So in between my case studies for school, I've been doing what I can. The gentleman that contacted Commissioner Amison and I, his name is Jeremy Hogg. He is on standby right now for any questions that you might have, and he is willing to come back in January and present a presentation for you guys too, so that any questions that I can't answer that he might have. So how it works is patients are referred by their primary care provider, and they're typically seen within 3 days by an on-site medical oncologist. These oncologists collaborate with a national team of subspecialists in breast cancer, lung, GI, GU, hematologic, and neurologic cancers to develop a personal treatment plan. Infusions are administered locally so basically they bring in their own docs, their own equipment, their own nurses. What is cool about this is they are willing to cross-train any of our nurses at Weems if any of our nurses are interested. Now, this doesn't cost us anything. They basically want to rent some space from us, either in clinics or in the hospital. What we would get back is ultrasounds that are needed for their port placements, lab work that is going to be needed probably every few days, and as well as CT scans that are going to be needed. So it will bring in revenue from the hospital via lab work, CT scans. They have a 24/7 clinical support platform, And this model is structured to benefit the hospital. Main Street retains only the revenue from the net new oncology services, while Weems retains all downstream revenue from imaging labs, surgical procedures, which we don't do, and pharmacy utilization. So they would not be utilizing our 340B. They bring in their own medications. We basically just store them for them in our pharmacy. This partnership aligns directly with our mission to expand access to high-quality care in Franklin County, and it strengthens our role as trusted rural health provider. This model directly addresses the oncology care gap in rural communities like ours, where patients often face long travel times, delayed diagnoses, and fragmented care. By embedding oncology services locally, we reduce barriers to treatment and improve continuity of care, especially for our aging population with limited transportation. They also, and I did a little research, they also do, I don't know if you're familiar with Remicade, is a medication for rheumatoid arthritis. They do like for superbugs and wound therapy, they can implement antibiotics for patients, so patients don't have to drive to Tallahassee or Panama City. If they're receiving wound care, they can do those in-house. If the patient needs a port placement, they send in docs and their own ultrasound guided to do that. Main Street maintains full clinical responsibility for the care they deliver, including the management of infused-related reactions and urgent side effects. A chemo-certified nurse is present during all infusions and trained to respond to reactions. And in the event they needed to be seen in RER, of course, we would take care of them. So most of these oncologists are from Ivy League schools. And Mr. Walker told me, Mr. Bowling, that you guys, Alliant, has a hospital that utilizes a cancer network. Can you tell me about that a little bit?
Yeah, we do. We have a hospital in Kentucky that recently did something similar to this, Kristen, where they have a cancer treatment center that they developed, and it's in collaboration and partnership with another entity that's providing the oncology, and the oncology is being provided through a tele approach, but the hospital and the cancer treatment center that they developed there on site does, and they are able to provide, chemotherapy and other various transfusions and so forth as well. So they have created and developed that in collaboration and partnership with another group in Kentucky as well.
And that's going smoothly?
Not this same group, but again, a similar type of relationship. And seems to be going well. Again,
so you've got a good outcome with it.
They did their ribbon cutting this year, so it's just getting started per se. But as far as the need for the community and so forth, it's been well received.
I will send out an email to all of you, too, board members, so that you can review my research. And if this is something that we want to vote on, or you guys are interested, I know we don't meet through the holidays for obvious reasons, but Jeremy is more than willing to. He's excited, and he really wants to come and talk to you guys to answer any questions that you might have that I probably can't. He's a huge supporter of our hospital and rural hospitals, and it seems to be going well in all the 900 hospitals that they currently service.
Who's Jeremy? Is that
Jeremy is, I think he's the rep for Main
Let's talk
Street.
to him.
I don't know.
Board member?
I don't know who you talk to, Duffy.
Huh?
What do you mean you talk to
You
him?
said he'd come talk to the board.
Yeah, you would.
He will,
Well,
Okay.
that's what we need.
Sure.
I'm excited
I mean,
about this.
because I can't answer all of your
Well,
questions.
I'd like to, I understand that.
Yes, sir.
But, like, I got a question. Who would do the referrals to them?
They're usually your primary doctor, and they
Primary
work
care.
with other networks, so they would work with TMH Oncology.
So they would work the TMH?
Yes, sir. They'd work
Okay.
with surrounding hospitals for referrals. Yes,
So
sir.
if somebody from Franklin County had TMH, then they could
Yes,
work
sir.
referral here.
To refer to our
I'd
hospital.
love to talk to 'em.
My question is, where are we going to put it?
Yeah, that was my major question.
That's my question.
My question was
is
how
where
much-
are we going to put it? How much space do
they
we need?
How
Right.
much space do they need?
Correct.
I mean, we don't have a lot of space, so
Right.
that's the biggest, right
I
up
agree.
front.
I agree.
David's already he's moving out of his office to put something in his office.
Well, James is moving.
Huh?
That's right. I don't know what we're going to do with that old CT trailer, but.
Where's James?
Thought.
Where's James' office right now?
EOC now, but he was in the back row.
Where?
In the back trailer.
Yeah, he was in the back of the hospital, but that's not.
You know, we have to, that's not feasible because he got other staff back there at the EMS trailer. So what we have.
It's a great service.
Yeah.
The only roadblock we have is space.
Yeah, so
Yeah.
we'll have to meet with him.
Mhm.
You know, we'll probably meet with him in January. You know, he can come to the hospital and meet with Court and I.
Right, he would love to. He wanted to come today, but I told him to pump the brakes a little bit and let me put a bug in your ear first before he got here.
Yeah.
Let's see how much space they need, and
Sure.
it'd be, I guess the clinics would be ideal, but you're full, aren't you? And we're talking about putting a pharmacy, you know.
And the,
Caravelle, yeah, but and then we have Weems West has that back room that used to walk around.
Now, yeah,
Do
I
the
mean,
drugs have to be separated as far as what we have versus?
yes, sir,
what they have?
absolutely,
Yeah.
and they'll
So you-
provide their own drugs. We just hold them in our
So
pharmacy.
we need a space for that too.
Right, and I'm pretty sure, don't you agree, Court, some of those drugs will probably need to be refrigerated? So we'll have to look into that.
So that's got to be
Yeah.
taken.
Well, you know,
so what we can do, we can put him on the agenda for the 29th of
Okay.
January, but then we can all meet with him prior to him coming here. At least
Sure,
we-
I'd love for him
yeah.
to come and just
How
talk to
about
us.
How about a double wide in the parking lot, so it's out there, all adapted for this, right?
All right.
we
Give it a
need,
chance to get off
we
the
need to
ground.
build something like hospitals. I mean, it's
Yeah.
getting to the point, we're running out of space.
We are.
And we're, you know, this is an excellent, service to our folks in Franklin County.
Yes, sir.
The
And
traveling gypsy.
I just like the fact that it's not only oncology infusions, it's superbug antibiotics, it's Crohn's disease, IV infusions, it's wound care, it's arthritis. Like, they do a magnitude of different infusions. It's not just oncology. So that's the part that really stuck out in my mind, is we could save
That'd be good.
tons of residents from having to drive either way when they could stay here locally and then try to build, you know what I mean, some of our network into that, because we're going to be doing the CTs, we're going to be doing the lab work. The lab work's rotating, changing all the time, so they're going to need consistent lab work. So they only get revenue from their oncology services, and they'll rent the space from us. Now, what that looks like, again, I don't know what he has in
So-
mind.
How often, or do you even know how often they'll be in the vicinity?
I don't know. I don't know. It depends on our patient flow, I'm assuming.
well, let's
Worth
talk
the
to
talk.
It's worth the talk.
Worth the talk.
Y'all okay with that? Bruce?
Yeah.
Oh, yes.
I think it's well worth our while to talk.
Let's talk to
So the 29th?
Yeah.
Walker?
Also, if we need to check and see if we've got, long-term lease for the EMS over in Caravelle.
Yes, sir.
If we do have to have a long-term lease on that property and they're moving out to Lanark,
Yes, sir.
then there's an option there that we may be able to dress that place up.
Okay. So everybody's in agreement to bring him back on the
Oh,
29th?
yeah, sure.
Yes.
Wonderful,
Okay.
thank you.
Yes, sir.
Thank you. Thank you. Thank you. Okay. Go ahead, David.
All right, and then, so we'll.
Anything else? Any board, got anything else?
No,
Well,
sir.
thank you, that was good.
Okay, and so Kristen will get more information to us, and we'll put.
I'll email all of y'all today with the research that I've compiled so that
Okay.
you can take a look at it.
And then we'll add them tentatively on the agenda for the 29th, but then we'll set up a meeting with him, Kristen, David, Courtney, Susie.
Mhm.
You know, we'll set up a meeting prior to that. All right, item E, we talked about the audit update. Item F, we spoke about the clinic retail pharmacy. G, Apalachicola Regional Airport update. Steve Kirschenbaum, interim airport manager, has been invited to our January 29th meeting to give us an update on airport activities. And so we'll invite Steve Kirschenbaum here. There was a question at the last board meeting, why not invite Steve, the airport interim manager, to give an update on what's going on with the airport?
Okay.
So he'll be at
Mainly
the,
the helicopter and the hangars.
Yeah,
Oh, okay.
yeah.
for Air Methods.
I mean, that's Air Methods. Now, I got on the agenda for Air Methods, we're talking about Air Methods agreement, there's a clause in their particular agreement that, Attorney Sheila and I, reviewed with them. And we'll have to bring that to the county commission because they want to add the limited liability statute question in there about Florida Statute 76828 that would allow them, to sue us in case they have, in case there are any negligence. And so that's something that the county commission gonna have to decide, because I think that is like a $250,000 cap if you're.
Right.
If you're.
Sovereign immunity.
Sovereign immunity, yeah. And so, if the board want me to, because this, we can't make that decision. The county commission have to make that decision if they want to go ahead and override that. And so I can put that on my report for the county commission meeting on December 3rd as well.
When you say override, you don't mean go above 250.
No, not go above 250, but just approve that 250.
Yeah.
Because we can't do that. And now the county may, if they do that, if they say yes, then we'll sign the preferred provider fee with Air Methods for the hospital service. Now, Air Methods would come in and serve the county anyway. It's just that they'll be our preferred provider at the hospital. I still hadn't heard anything about the hangar out there. I did email Tommy Cochran to see if they made a decision about bringing Air Methods in the county. So I hadn't heard anything back from him yet on that. But that's two separate things, from the hospital agreement.
And you know that there are grants via DOT to the aviation branch available. So again, a grant writer, and that seems to be the one thing we're gonna have to figure out.
Yeah. And if the hospital, Julie Dennis write good grants for Calhoun Liberty. She's been doing that for years. Of course, we've been writing our own grants here at the hospital.
Right.
But if the hospital the board want us to look at, bringing a grant writer in on staff here,
Yeah, you've been doing good. That's
But part of the collaborative, we will have somebody to help write grants for that. Now, multi-view agreement, the same thing. They have they want to put the $250,000 cap in there as well. It's up to the board. I don't know if the county would go for multi-view approving that, because it's a financial operations system. It's really not a life or death kind of deal, but they want this agreement in the contract that we have with them.
So are you saying that they want to be able to get the county's sovereign immunity cap for them as a private corporation?
Yeah, that's if they need to sue us for infringement or.
Wait, who's gonna sue who?
Well, that's at Multiview.
Huh?
Yeah.
Multiview's gonna sue who?
Well, Multiview will sue the county, us, because we're part of Weems Memorial Hospital, Franklin County Board of County Commission, DBA, Weems Memorial Hospital. A part of their agreement, they want in here that if we breach the agreement, or like sell their intellectual property, if something like that happens, they want to be able to sue, the county government or the state government,
Well, they can do that tomorrow.
Well, they can, they can, but they want.
And the maximum they could get is 250.
I know, but they want us to sign on it. They
They
saying.
want to waive us to waive the 250 is what they want.
Is that what you're saying?
Yeah.
That ain't happening.
No. You don't give up sovereign immunity.
But if you enter into an agreement, say, okay, you're not giving up the sovereign immunity, but if I can sue you, for that 250, baby.
I'm not following.
They can anyway, David.
Yeah.
They can sue us for 250 anyway. I think they want us to waive our right to the sovereign immunity so that they could sue for 500 or so. I believe that's what it is. They can sue us for 250 because that's the limit. That's the limit on sovereign immunity.
Yeah, and then
I think you're right.
Yeah, and then so Attorney Schuler looked at it. That's something that if the board, wants to go to the county commission to add that the clause that they want into the agreement, Attorney Schuler's not too fond of adding that clause in. I'm not either, because it's not a life or death kind of agreement, but it's a financial operation piece. Yeah.
Go ahead.
I think they want our cap.
They want our cap.
Wants to cap. They want their private corporation to be capped at 250.
Oh yeah. Okay. Yeah.
Okay.
Okay. Probably that. Well, let's move on. That's the county's business there. So.
Yeah, so I'll put it on part of my agenda to the county, and then if the
Thank
county say yes, they can do it. If they say no, then
No, that's
we
the
won't
county.
contract with Multiview,
That's
you know.
county.
All right. Thanksgiving holidays, Courtney mentioned that. The radiology agreement, there will be before the county commission on December 3rd. So we got quite a bit, at least 3 items will be before the county commission on, for approval on December 3rd. And that's it. And then we got the Alliant thing that you'll talk about in a minute.
Oh, we got, the foundation, Bill.
All right, so we had a great party. We did raise some money, but we're gonna find out on December 9th exactly how much money we did make. We still got some invoices outstanding and some sponsor drive donations, et cetera, coming in, so we wanna pool all that and get a definitive. We had 135 ticketed guests, plus sponsors, plus volunteers and vendors. We had 14 volunteers that day who came in and did stuff for us. We had the 360 booth and the photography that's out there. We are seeking some other sponsors and covers for future events. I think looking back at, did it go well? The Apalachicola Yacht Club called us 2 days afterwards and said, are you guys gonna do that again this year here, or next year here? And so I think they wanna do it next year on a Saturday, so that's good.
That was
they-
one of the
that they liked
problems,
it so
Bill,
much.
is a lot of people worked that Monday. That
Yeah.
was one of the problems, is
Yeah,
it was on
that might have
Sunday.
been. So if we get it on a Saturday, that would
Yeah,
be
exactly.
They are
probably
inviting
better.
us back.
Oh, yeah,
I
they
like
want us
that-
back.
I like that snacks and
Yeah.
everything.
They want us back.
Enjoy the libations.
Yeah, the food was good,
Yeah,
the
libations were
music
good,
was good, so every feedback that we're getting,
Absolutely.
and he said, Clayton at the Yacht Club said that several patrons who go to the Yacht Club said, when is that gonna be again next year? So I think it went well. We did get some auction items sold. We sold signed Dolphin helmet, Jimmy Buffett Fender guitar was signed, autographed guitar, and a Kiss autographed guitar was also sold. So we got a couple guitars and helmet and some other things off of the auction that sold and brought in some extra cash. So I think it did well. We're very happy with it, but you know, going forward, we definitely need as much support as we can get from the board and the hospital and the community. So definitely looking forward to next year, but we're gonna take a little break until about February, I think.
Yeah, Colleen and I talked about having a car show for the foundation, so I'll get on that too in the springtime. A car show.
Car show, they love car shows.
People love car shows.
People love car shows.
Really?
I like that.
Okay, next item, new business. I got something that I'd like to bring up. We got a lot going on. In the future, we need a lot done. And I would like the board to look at this after we look at some other stuff about Alliance contract. I think it'd be beneficial to us if we went back to the original contract. However, and I'd be willing to talk to the board about it. I don't know what. Before we did that, I would want to go talk to the county. Everybody remember, this is a county decision, okay? However, the board is supposed to
Make a recommendation, right?
make recommendations, or can. But there's some things I'd like to know that I need information. You know, this is example, and I'd like all the board members to think I want to look at the Alliance performance from when did Alliance come?
5 years ago.
David? When did they come? What year?
2020?
2020?
Yeah.
Right during COVID, right?
Yeah, COVID, yeah,
Right
2020.
during COVID.
Okay, was COVID going on then? COVID wasn't going on then.
Yeah.
Sir, it was.
Yeah, Doug Kramer passed away 2020.
Well, then the numbers aren't gonna look right. But what I was just thinking, number one, after COVID, a lot of rural hospitals went out of business, and we didn't, okay?
Thank God.
But I would love to see what cash on hand was when y'all took over, versus now. This is just me. I mean, the first financials, what was our cash on hand? Unless it was inflated by COVID money. We hadn't, I don't know if we got the money.
Yeah, it was getting inflated because we got the CARES Act, what, $3 million, I
Well,
believe.
that won't count. After, some way there, I'd like to see what our actual cash on hand was minus the CARES Act. Even though that was true cash on hand, that was a little different there.
Well, I think what you're saying is you want to do a little review of the performance
Exactly.
of Alliant over the course of the years that we've had them, and,
Yeah.
and what position were we in before we had them, and where are we now? And I think you're going to see a very positive result
Well,
with
you could
regard
even
to
go
that, but we need to look at it.
But see what, you know, and what I'm thinking is the cash on hand. One of the commissioners had mentioned, right if y'all come on it, of what we pay nursing. And we've, with the whole hospital staff, we've taken an initiative to make sure they're paid up to par. Now, I do believe that Courtney, our nurse, our pay for RNs, are we getting closer to everybody else, or do you feel comfortable with it? Do you?
Honestly, I don't
You don't
know.
ever feel, you always want more money, but
I don't ask you like James does, but I'll take it.
but
I really don't know what they making next door to us. I think we're comparable for what we serve and what we do.
Are you
Yes.
talking about Sacred?
Well, that's something Alliant could also benchmark for us, what's being paid at other hospitals within the region against what our pay scale looks like too. So,
Yeah.
you know, we can get an hourly rate figuring what, you know, certain LPN, RN, whatever, are making at other hospitals and see where we stand.
are the
So
staff
we could do that.
generally pleased with their salaries?
Yes, sir, I believe so.
I mean-
But of course, we're always generally pleased with raises.
I know I know I'm putting you on the spot. I shouldn't even ask her.
Well, just Courtney,
You know,
Do we have shift diff court for
We do.
weekends?
We do. We have
Weekends
for-
and night shift, correct?
That's correct.
I would like to look at the audits reports, then versus now. I'm trying to get some, I guess, call them benchmarks,
Yep.
some things. And that's the only way we can look at the performance, which I think I wouldn't, and this bill at the board, I wouldn't ever want to ask the county to do something different unless I have some facts on hand. Easy to read, okay? And there's some folks that are here, like our performance in the clinics. What we see in the clinic then, on a yearly total, what do we see? You know, what we're seeing the year before y'all came and now.
What
Which I-
did you bring to the table, basically?
Yeah, what'd you bring to the table? Now, if I'd like the other board members to shoot David an email, this is no rush to do this, and what other benchmarks would you like to look at? Okay? Y'all know some of this, particularly with the financials, which is what we're concerned about. I'd also want to know when a real short document, when Alliant came on, what programs, treatments have we added to what the hospital offers? Okay, and I think we've got quite a bit. Correct?
Yeah,
We've
Yeah,
got quite a
you're
bit.
right on target.
And look at maybe the revenue, gross revenue. Now, I know expenses went up because we're giving the salaries and stuff, but also our cash on hand has gone up. So I'd like to see that, and I don't know if we can get it by the 29th, but it should be a pretty simple thing to get.
Well, Mr. Chair, I'd also like to look into tuition reimbursement for our nurses, because that's a driving factor. If you've got an LPN that dreams to be an RN, or you got an RN that wants that BSN, or you got a BSN nurse that now wants to complete her nurse practitioner, I mean, Sacred offers tuition reimbursement. I think we need to look at that, because I
Yeah,
feel like
sure.
we would get an influx of nurses because that's a huge driver.
Let
You're
me
gonna
ask
pay
you-
for
I
me to go
agree.
back to school, And as I understand, our BSN nurses don't get any more money for having a bachelor's degree. Okay,
That's correct.
That's insane.
That's correct. They
You
pay for
should
the
get more money.
education on their own like I did, and it cost me thousands and thousands of dollars. and-
Same, sister, same.
And
So
I'd
feel
have
like-
my master's right now if it was paid for.
Yeah, exactly. So
Well, let's-
I'm blessed that
Or
I have a
assisted.
husband that is helping me and support me to get my master's. But in the event, I worked hard for my bachelor's degree. TMH compensates for your bachelor's. They give you $5, $6 more an hour, and you should get that. You studied longer. You're more on the managerial side. You can lead a floor better, and you have more knowledge with the bachelor's degree. You should be compensated for that. So
Well, I
tuition
think we're-
reimbursement we need to look at as well as.
It sounds good, but I think we're on a different topic than we were previously.
Yeah, let's hold on a minute.
Let's stay on one topic.
Let's get back to that. Let's get back to that. Let's get back to that.
Plugs in.
Commercial.
My degree cost me, my degree cost me thousands of dollars too. I just want you to know, okay? It all cost us all thousands of dollars.
So I think what you're saying, Duffy, is we want to do a little,
wanna
a
help.
really nice dashboard sheet
Yeah.
of the performance that Alliant has driven for this hospital. And once we have that in hand, I think the end goal that we want to look at, and I think we talked about possibly discussing this with the board, is that we'd like to have Alliant, if this is what we find, we'd like to have Alliant have a longer contract, perhaps a year-long contract with us, because we feel that with them, with a little time skin in the game, they're going to be able to provide better support for our organization going down the road. Right now, if I was on a month-to-month with you, I'm not going to put a lot of time and effort into the needs of your organization. But if I've got a one-year contract with you, and I know that that's going to be renewed, or I know that if I do well, that it's going to be performing well for both of us, I think that's a win-win. And if we get that sheet and we take that to the Board of County Commissioners, and our recommendation may be to the Board of County Commissioners, hey man, we want to extend Alliance relationship with us, their contract to a one-year contract rather than a month-to-month.
Well, maybe 2 years, maybe 3. I'm not sure,
Yeah.
because we're looking at stuff 2 and 3 years in the future
Yeah?
right now with this act, this money coming from the government right here. And another thing we do, I would like to see what boards, influential boards, that David's on, both Davids, and maybe you, because that helps us. That helps us. It will. You agree?
I agree.
I mean,
I agree.
that interpersonal working, if you pick up the phone and call somebody to answer you, you can save yourself a lot of time and money, and that's good.
Well, especially with your partnership with like helping us with the bonuses and the retail pharmacy. And you guys have your hands in the cancer stuff. You guys have your hands in trying to help us make a network instead of just an ER or just a hospital. So
Well,
that partnership is valuable.
Yeah, well, we don't need to reinvent the wheel every time we do
Right.
something. These guys have invented the wheel with other organizations, so that certainly helps us, give us a leg up on any pro forma issues that we may have, or the other services we want to bring in that somebody else already has. So it's a valuable relationship for benchmarking and for pro forma and for other needs to give us a little knowledge in advance of making a decision that could be disastrous.
Let me tell you something too, y'all. The month-to-month, Alliant could leave. Let's don't forget that. I mean, don't think you will. And I hope
I
you
don't foresee that happening.
But I'm just saying, that's part of the contract, and I would like to feel like somebody is part of our team here for a longer time. And
Absolutely.
you can't run the hospital month to month. It don't work. But I'd like to ask the board members if they got some other ideas about, I guess, where we were and where we are now, I know,
Take a look at,
Just for the board members, this is the county commission, they named it back when Alliant came aboard, a dashboard. So this is the operational dashboard. You can look at this some information too and say, hey, I want to make sure we highlight that as well, because this tells you, it goes back, I think we can take it back to the time maybe when Alliant came, but I know we go back to 2023. So we probably can take it back all the way to 2020, 21, whatever. Then you can see the real data.
Well, you can look at my Technicolor graphs too, and you see all that. You can see where those lines have gone.
Okay. Well, can y'all put that together?
absolutely.
It shouldn't be too difficult.
No, I
know we
mean,
got a lot going
that's
on.
perfect. No, yeah, definitely pull that information.
But-
Any other information you want to see, just shoot me a note. I mean, we certainly value the partnership and
I know y'all do,
the
but
relationship, and
I
we
would
wanna stay
feel more
committed.
comfortable.
Yeah.
Yeah.
I
we
would feel
absolutely-
more comfortable, if with the contract being for a longer period of time. Of course, you still always got some stuff to, either side can leave the contract, and that's ought to be in
Also,
it.
I think they ought to provide us a listing of what they are going to do in the future,
Sure.
provided they get a longer term contract.
Well,
What is- what is
Well,
your
John, you just,
future
John,
provided?
you just mentioned something, and again, I want to share this, with the board, is that, we are planning in '26 to do, strategic planning for the hospital. I mean,
Yeah.
you are in that cycle to where we would want to sit down with the board, lead a session where we involve key stakeholders in the community, the county, and anyone that you guys and the county deems that should be involved with that process. What do we want to be? What does this community need for healthcare in the community? We want to formally do a strategic planning session. We'd love to do that in the spring.
Now, the question's gonna be, I'm gonna play devil's advocate. Have you done this before?
We have.
Yeah.
And it's been published?
Yes, sir.
Okay. So you bring those.
Yes, sir.
And then you look at your benchmarks that
That's right.
you've grown over the last 5 years.
That's right.
And that should give you assurance that you're doing the right thing, right?
Well, we look at it every month, too.
But this brings another question that I've got in my mind, and I just need to know.
We're not gonna give
I'm
up.
not gonna give up.
Told y'all to bring
until I hear
potluck.
the
Nobody
answer.
listens to me.
And that is, on our billings, how do we measure that company that's doing that work as far as rejections and recovery?
We have a
Okay.
dashboard for that too, John.
We do. And we meet weekly, and they track all the denials. Anything that needs to come to me, I handle. And they also track and trend. So, for example, we had an issue with taxonomies, denials for taxonomy, which just wasn't right, from a lot of our Medicaid managed care companies. And they set that aside as an issue and addressed it with the payers directly.
Okay. So you've done this in the past. So that's should have contributed a certain amount of cash to this
Improvement.
organization. Does that cash have any relationship to what we see as far as days on hand?
Yeah.
Sure.
A lot.
Okay.
Sure.
But we haven't explained that. We have the good job these people are doing,
Excellent job.
our people are doing, okay, to where we were with how much we were recovering as to where we are now.
Our collections were not up to par, and there's been a lot of work done on that.
That's right.
There's been, I don't know how to capture that, maybe
Sure.
you
And-
can capture
well, I
that,
mean,
but
it-
collections is part of it too.
Yeah, and John's point, I mean, it's doing business. I mean, you can contract with multiple third parties, and folks do, but you got to hold third parties accountable. And that's where you see improvement. If you're not holding third parties accountable, they get comfortable with the margin and the flow of work they're doing. But you got
Right.
you got to drive better results with third parties as well. And we've seen it. We've seen some improvement here. There's a dashboard, to your point, that's got lots of different metrics and so forth on it. That is circulated every month. And as Heather pointed out, they do participate in frequent discussions, actually weekly
We do.
calls with that third party, just to stay on track. Are we hitting the KPIs that need to be hitting? So, yeah, that's available. But back to the original request, absolutely, we can pull together this information that you requested. Any other information, anything you guys think about or think would be helpful?
I'll be thinking
And we value the partnership,
Yeah,
and we want to, we want to stay committed with this as well.
Okay,
And,
when did
we'll
we
provide
have
whatever's needed.
the retirement benefit? That was,
That was in
that's when you came on.
21.
Okay.
Yeah,
Yeah, we started that, yeah, that came about.
4 years ago or something?
Hmm?
Maybe 4 years ago, 3, 4 years.
3 or 4 years ago. And I know that's one thing that we never had any type of retirement. And so I'd like to look at all that and to see and show it if we decide to go on with that.
Yeah.
But I'd like some input from the rest of the board. Y'all be thinking about some stuff. Like
We will.
Okay.
Now, Deb, I think we skipped Kozar on the agenda.
Oh, yeah.
Is he still here, Mr. Kozar? Are you
Michael,
still
I'm
here?
sorry, Mr. Kozar.
I'm still here.
I'm sorry.
Quiet as a church mouse.
I'm sorry.
No,
He probably can't get a word in.
No, we covered a lot of the stuff that I was going to bring up. In the interest of time, the only thing that I wanted to mention is that, the employee engagement survey has been completed, and they should be getting the results here in the next couple weeks. So we'll be able to share with the board the results of that survey that Alliant provides to the hospitals as far as the employee engagement survey. But yeah, in the interest of time, I know this has been a long meeting, so I'll just keep my comments to that. So
Okay. Okay.
Thank you.
Thank you, Mr. Kozar.
Uh-huh.
Why don't you call David
Sir?
and get that on the agenda about the paying extra for the bachelor's degree and
Yes, sir.
also the reimbursement, something.
For
Let's-
tuition?
Yeah, let's get it on the agenda.
Yes, sir. I sure will. Thank you for that.
And Miss Alford is not to be in on this right here at all. Look at her.
Well, we're not even.
I already know where she stands on this. I know where she stands.
Well, it's not only nursing, we had other clinical areas also.
Yeah, absolutely.
Yeah,
I don't mean to
understand.
single us
I
nurses
understand.
out, but at heart, I'm a nurse.
Yeah, so we want to look at, we'll look at them also. And that's something also when a line say, okay, what we're going to do for the future. You know what I
Correct.
mean? That can be a benchmark there.
Because we're just investing in our own employees to just get a better
Don't forget
education.
the housekeepers. We gotta
Yeah.
keep them,
That's just a thorn in my side about the housekeeping there. And, I just don't, I think that can be resolved
yeah.
some way. Okay. Is there anything else? Thank y'all. Y'all have nice
Make a
holidays.
motion
Now,
we adjourn.
with all this going on, we might have to have a pop-up meeting. So and I want to make sure everybody understands that this board will do what we need to do to carry through with some items. So y'all have nice holidays, eat too much, and
Yeah, happy
Happy Thanksgiving to everybody.
And if you can't make it, Michael, Royce, you want to come out tomorrow, you can
Love
at
to.
the
I'll
hospital
go to the funeral.
at 12 o'clock.
Bang the gavel.
I like to do
All
this.
right,
Hey.
Reese, wake up.
I